And then when we go back, we will also start engagement with our colleagues in the WA-RCC, and then we'll sit on the same table to start working on the plan. Then we jump that portion. We go straight to the AHSS agenda. We have Prof. Aliko will also be doing that. Is going to be moderated by Walter. But in this case, Prof. Aliko's presentation, I was able to review, and then I realized that it's also been captured by Jibril's presentation. So I had a discussion with him, and Jibril will now present for both the AHS and as well as also the Lusaka agenda. So in this presentation, all these things are going to be captured. So just to save time, we really want to give you time to enjoy Accra, and so that we can also be able to review the agenda for the RESCO. We also have the agenda. Samuel, I'll share the agenda with you online, and we also look at the agenda. Then from there, we go to the data sharing agreement. Our able legal practitioner, Madam Habiba Ahmed from the legal division, will lead us into that DSA. Again, another panel session, which is going to be moderated by Dr. Elfas. So, Dr. Mariam, you your people and do the introduction, and then you'll be one to start with the panel session. So I want to start by 9. I cannot wait for everyone. And we also have a regional roadmap, which is also going to be facilitated by Dr. Elfas. And then from there, we have the ReTAC elections. Again, Dr. Habiba will guide us on the election and who is eligible to be elected, and then who is eligible to vote. She will guide us into that. So that's why we have her here. She's very important. And today is her day. She is going to take us through all this. So we are happy to have you, Dr. Habiba. If you are not here, we are not going to have election. But we are going to have the election because of you. And then from there, we look at the key recommendations. And then also we have the closing. If I can have our way, if we can definitely work towards closing by 2 p.m. or 3 p.m., that would be great, and that's my plan. And I wish we can close by 3 p.m. if possible. So let's reduce our number of discussions that we have. We can create key points. We can bring in our key points, and then we discuss. But if we want to deliberate on everything, we might not leave here on time. And some people really want to explore the city. So I want us to go straight to the topic by 9 a.m. I will call on, I think the panelists we are going to be told. Dr. Mariam, anything from you?
Quoi que ce soit à dire.
They are not here yet.
Les panélistes ne sont pas encore présents.
Okay, so we still wait. Or we don't go into the other topic. Then we will. Okay, that's fine. I want to. Now, if that's the case, we are going straight. We are not going to have the work plan review. We are not going to have that.
faire la
of the
revue de plan de
regional.
travail.
We're going to have a bilateral with
Nous allons avoir des
our
discussions bilatérales
brothers.
avec nos
So
frères
from ECOWAS-RCC,
de la
CDC,
CDAO.
they are our brothers and sisters.
Nos
So we're going to have a
frères et nos
bilateral to
sœurs.
work on
Donc, nous allons
because
tenir
we
des
had one
discussions
plan and that is
bilatérales
expired.
parce que nous
So
avions
we
un
also
plan de
need to work
travail
on
qui a
another plan,
expiré.
which
Donc, nous
we
devons
will
travailler
definitely
sur un
review.
autre plan que
Perhaps
nous
in our
allons
next ReTAC
réviser
meeting, we will
peut-être
definitely
lors de la
discuss on
prochaine
that.
réunion du ReTAC. Nous allons discuter
Then
de
we
cela.
go straight to the
Et ensuite, nous
presentation.
allons entrer de plein pied dans
Can we
la
call Jibril?
présentation. Jibril,
Então vamos começar
Jibril.
com a apresentação. Vamos então convidar Jibril.
Jibril, I was saying
Jibril,
your
disais
presentation
que
will be the one we are going to
que
start
nous allons
with.
commencer avec la
And I had a discussion with
J'ai
Prof.
discuté
Aliko
avec Prof. Aliko.
that the AHS agenda
L'agenda
will be
AHS
captured under your presentation. You look at the
sera
5 pillars,
partie de
and
votre
as
présentation.
his
Vous avez
statement
discuté des
indicate,
4 piliers,
there are
comme
5
il a
pillars
dit.
in the AHS
Il y a
agenda.
5
So those
piliers
5
dans
pillars,
l'agenda AHS.
this
Et
is what you're also going to elaborate on during your presentation, and then go to the Lusaka agenda. So you have 2 components to present. I've already agreed with Dr. Prof. Aliko that the AHS agenda will be captured by you, and then also the Lusaka agenda. Then after your presentation, we are going to have Dr. Nabil. We expect a presentation from the headquarters, Dr. Nabil, after Jibril's presentation online. And then we also have a presentation on Dr. Arnold will do a presentation on the FEM together with colleagues from headquarters. And Dr. Arnold will also, or Dr. Mariel will do the, I think some of them will, one of us will do the AMR governance study, and also I will do the PSC continental coordination mechanism, primary healthcare continental coordination mechanism. What is it all about, and what we have agreed in Addis Ababa on the outcome statement. I just summarized the outcome statement of the primary healthcare continental coordination mechanism. And we are calling on all the member states partners to be part of the primary healthcare continental coordination mechanism at the regional level. Because we have the various structures, continental, regional, and we want to replicate that at member state level. So that is where we are. So I'll now call on, Habib, are you set? Just to start, DSA will be the first one, then Jibril, followed by Jibril. Are you ready? 2 minutes? Okay, so you want me to give her 2 minutes. So the presentation in order will be DSA will be the first one. No, it's not you, Habiba, sorry, it's not you. It's going to be started. We are jumping the first part of the morning. We are not doing anything on that one. That is the work plan with ECOWAS RCSDC. We are jumping that. So what we are now starting with will be the presentation on PFM. Jibril will do the presentation, yeah. So it will start with Jibril. So Jibril, your presentation will cover the AHS agenda, the 5 pillars, and then after that you also move to the Lusaka agenda. I discussed with Prof. Aliko, so he has agreed that you continue with the presentation. Okay. So Jibril, we want to welcome you now to take the floor. And the chair for this session is Walter Onditi. Walter, you'll be moderating for all the whole morning. You'll be the one facilitating up to around 12 o'clock, then Dr. Elfas will pick up from there. So Walter, the floor is yours. Oh, sorry, no, Kelvin will come later, after when Mariam's panels are, when the panel is ready. Yeah, the panel is not incomplete, it's not complete yet. So call your professor. No, it's not coming. So do everything. Yeah.
Okay, fine. So then for that I call the other.
No, call Gabriel first.
Okay, Gabriel.
And then from there, who's coming next? Nabil.
Nabil.
Yeah.
Okay, fine.
Do some light.
Okay, fine.
Good morning, everyone. Gabriel, it's your turn. I'm not sure if you are ready. You are ready? If you're ready, come over. After that, Nebiyu, if you are online or you are listening, perhaps get ready. And then after that, I think that's all. Those are the two presenters that are there, now given that the prof is not there. Is Nebi online? Is he online? Nebi. We give a moment for the setup to complete. Gabriel, yeah. He's ready. I think they're just doing a setup. Gabriel, do we let Nebiyu to go first while the setup is done? Or we wait. Okay. So, yes, I think Gabriel is ready. Okay. Yeah, you are. So you need to greet people.
Good morning, distinguished ladies and gentlemen. Permanent secretaries here present, partners from the development arena, director generals, colleagues from the health sector, members of the Africa CDC, RCC, Prof. Aliko, SRR, and the RD. Good morning to you all. It is a pleasure to share with you the new direction of the Africa CDC in relation to public financial management and Lusaka agenda, particularly what it means to be for West Africa. The central message I would want to put across or leave here today is simple. It's about health financing. Health financing is not only about how much money we actually mobilize. It is about whether that money reaches the right priorities at the right time, and it is spent efficiently and ultimately produces better health outcomes. And that is where PFM actually stands, and that's where the Lusaka agenda comes together. So introducing the PFM and the Lusaka agenda, at the heart of this very agenda is a very simple results chain. When you look at it critically, it tells you that better planning, better financing, better performance, better accountability will eventually lead to better health outcomes. And I say the ultimate objective aim of a health system is to provide quality healthcare service delivery. Is to be able to detect diseases on time and respond on time. Is to be able to provide the highest quality human resource possible for a nation, in order to be able to actually, provide the quality healthcare it deserves. PFM provides the system through which government translates health priorities into budget, expenditure, and results. The Lusaka agenda complements this by strengthening country ownership and aligning external support behind the national priority. So these are not two separate agendas. The Lusaka agenda and the PFM agenda are not separate agendas. Together, they address a fundamental question. How do we make every available health dollar, or CD, or Naira, or Dalasi, or CFA provide better health outcome for our people? So our destination is stronger health system, sustainable financing, and health security, and ultimately greater health sovereignty. So moving on to the Africa Health Security and Sovereignty Agenda. The slide, please. This work sits within the Africa CDC broader agenda for Africa Health Security and Sovereignty agenda. When you look at the 5 shifts, they call it 5 pillars, but most of the Africa CDC leadership prefer to call it the 5 shifts. The 5 shifts because it is not business as usual. It's not actually business as usual. Sitting at the core of this 5 shifts is the predictable, domestic, and innovative blended health financing. Those in the health space 20 years ago, you realize that when global funds started coming in, accountability was not a priority for global fund. In 2004, 2005, when they did the mass bed net distribution or bed net dipping using parametry, if I could fully remember, then we were young officers in the field. Accountability was not a priority. They bring money to the country, put money in bags, give it to officers You go and do the bed net distribution, you pay people, you just tally and tell people how much you have distributed and how many people you have covered. But that actually gradually changed. And now, Global Fund, for example, is talking about public financial management. It's talking about the dollars they are spending in the health sectors in the sub-Saharan Africa. How much is it actually impacting on the lives of the people? They are talking about integrating the financing into the national budget. They are talking about the one budget. So this is why it is not business as usual for us to continue implementing the same way we have been implementing before. Because donors are talking about transparency, accountability, value for money, efficiency, effectiveness. These are now the words that they are pushing. And Africa CDC cannot be behind. So if you look at the pillars, the heart of this pillar is just, this is where public financial management sits. And the reason why it is a critical pillar is because we've realized that after the Trump coming into power, funding. So our citizens suffer because another country have decided not to give us aid. So our country citizens suffer? No. So we need to make sure that every dollar, every naira, every dollar, every CFA, every CD spent in the health sector provides the maximum outcome for our people. So this is why the framework has this framework has 5 interconnected pillars, which is from reforming the global health architecture, strengthening preparedness, moving on to financing, digital transformation, and local manufacturing. For example, when we talk about local manufacturing, we all witness to the COVID-19 pandemic, when stronger and bigger countries were diverting, supplies, when less privileged nations were unable to actually get the supplies they deserved. And people were thinking that if COVID-19 hit Africa, it is going to wipe us out because we do not have, and we do not have the PPEs. This is why it is a priority for Africa CDC to pursue the last shift, which is the local manufacturing. financing is fundamental and a health security issue. So moving on to the health sovereignty, and this takes us to, I want to briefly, define what health sovereignty is. But as you can see on the screen, the health sovereignty means African countries increasingly having the capacity to finance, produce, and govern their own systems. The principle is powerful. It is country-led, and at the regional level, the regions coordinate, which is the Africa CDC, supports in the coordination, and the global partners, like the partners we've seen on the high table, here yesterday, actually supports the agenda. So for PFM and the Lusaka agenda, this means we must generate African-led thinking, developing approaches grounded in African realities, and produces evidence from African reforms and contributes knowledge to the global health discourse. So health sovereignty does not mean Africa working alone. It means African countries increasingly having the authority, institutions, and financing capacity to determine and deliver their own priority. So moving on to what the PFM and the Lusaka agenda is for the Africa CDC when they created the new Lusaka agenda, PFM and Lusaka agenda division. Samuel. So the mandate of the division essentially is to translate health financing strategies into implementation. So what we are now thinking as a continent and as Africa CDC is to actually move away from the traditional way of supporting health financing reforms. So what we do is we will support to strengthen PFM systems that are currently existing in the country, improve expenditure tracking and accountability, and align domestic and external financing as well, and also support coordinate partners and build capacity across the ministries of health and finance. So Africa CDC is now working towards bringing these two ministries together. Traditionally, when support comes to the health sector, it concentrates on health economics. But now, to make sustained gains, we should actually move and integrate the Ministry of Finance as part of the process. So our deliverables are clear and deliberately practical, meaning public finance performance, scorecards, expenditure tracking, dashboards, technical support, and also capacity development and country reforms reports. I particularly want to emphasize the phrase on this slide is Africa CDC implementation engine. We are not establishing another platform simple to discuss reforms. Our value will be to measure by whether reforms are actually implemented, monitored, and sustained in member states. So the guiding principle for this new work will be how do we work and what do we do to implement our agenda and create impact. So 3 principles. 1 is partnership and collaboration. Building on existing works and reducing duplication and the burden on countries. So what we are going to do is not to reinvent the wheel, but to step on the existing PFM and Lusaka agendas in countries to spring. So our intention is to reduce as much as possible duplications, relation to this agenda. And the second focus is the country-centeredness. Countries must own the reform agenda. We must support them rather than substitute for them. We are not substituting for you. It's your responsibility to take the lead. It's your responsibility to accept the reform, and it's your responsibility to maintain and sustain the reforms. So we will bring you the ideas, bring you the technical assistance, generate the evidence to direct you, to support you in the reform agenda. And the third focus is the results focus. We prioritize reforms that are consequential and catalytic, meaning we don't just want reform for the sake of reform. No, we want reform that can provide, impact. So going forward, the next key priorities for Africa CDC for the next, 5 months, will be to bring first efficiency is very key. Helping member states improve spending in high impact areas such as human resource, medicine, and medical supplies, and also primary health care. If you review the strategy plans of most of the states, they will tell you that investment will be, primary health care will be prioritized. But when you do your analysis of the expenditure, you realize that primary health care get the least percentage, and yet it contributes to almost 80% of the first contact. Primary health care is at the periphery. This is where our population seek care at first when they have fever, when they realize that there's something wrong in them. That's the first point of contact. But yet still, that point of contact is not well funded. The basic tests are not available in order to prevent the relocation from primary health care to the tertiary care. So most of the referral is as a result of lack of adequate funding in the primary health care, for example. So the second priority will be, domestic financing, support reforms that make health financing more sustainable and also resilient, meaning reforms like, budget allocation, developing budget allocation formulas, quarterly budget reviews, analyzing the budget on a quarterly basis, and the permanent secretary or the director general sits down to look at that budget with the minister, said, oh, we are spending more on hospital A. What is the impact? We are spending more in region A. What is the impact? We are spending more in primary rather than tertiary. Or we are spending more in tertiary rather than primary. So that the discussion will take place. So that awareness will be created for the management to be able to make informed decisions. And third is the support we are going to give is going to be a medium term to long term, is one plan, one budget, one report. This is where the donors are now thinking. This is where all the development partners are now thinking. Why do you develop 2, 3, 4 strategic plans for a health sector? Why do you have, different M&Es? For example, malaria will have M&E, TB will have M&E, EPI program will have M&E, mental health will have M&E. And in some ministries, you don't have a centralized M&E framework that coordinates all these small M&E. So you realize that there is so much fragmentation in the health system in terms of reporting, in terms of budgeting. So this is what we are going to also support, because it's a vision now, even with donors like Global Fund. They are pursuing that their funds should go through the integrated budget, which is the one treasury account. That's the agenda they started discussing 2 years ago, and it is live now. They've now translated now from a single disease application to now a consolidated disease application. In this GC8, countries should submit one Global Fund request. So gradually, they are pushing us. So before they get to our neck, let them find us already prepared as a continent, that wherever they want us to move on, we are already on track in that area. So on the Lusaka agenda, we are strengthening the awareness and capacity, finalizing the Lusaka agenda, monitoring and action framework, and also establishing baseline, consolidating country plans into a continental roadmap, and activating governance arrangements, and also strengthening collaboration. So the common thread across all these priorities, which is the Lusaka agenda and the PFM, is country-led implementation. So the challenge before us is no longer simple knowing what reforms are needed. It makes those reforms happen faster. So why is PFM a priority? Why? So when you look at it, you realize that because the financing trajectory tells us that business as usual will not be enough to achieve our intended goal. So the data shows us that spending increasing over time, but important financing gaps remain. Per capita spending is improving, but progressing is uneven. So the important point is not simple whether, it's simple whether health expenditure is rising. Yes, it is rising, but the real questions are, who is financing that increase? Who in our country? Who is financing that increase? And is the financing of that increase sustainable? And are those resources producing better outcomes? These are the three questions we should be asking ourselves, as Secretary Generals, as permanent secretaries, as head of departments, As I said earlier in the opening, every dollar spent should result to a meaningful impact. So this is why the Lusaka agenda and PFM is emphasizing on efficiency and domestic financing and accountability. So our task is therefore not simple to advocate for more money for health. It is to ensure, as I said earlier, that available resources, additional resources, deliver more health for every dollar spent, for every CFA or Naira or CD or dollars is spent. So why these priorities? So the West Africa perspective. This slide makes the challenge even clearer by showing how financing differs across regions and in income groups. For us in West Africa, I will draw attention particularly to the financing mix shown here. The role of domestic government financing alongside external assistance and substantial household out-of-pocket expenditure is really worrying. And this is where financing becomes personal. You will see that the greater expenditure is out of pocket. As I said, should we sit and see our people pushed into poverty because of access to health? No. So this is why domestic resource mobilization is important. So when public financing is insufficient and people must pay directly at the point of care, the financing gaps move from the government budget to the household budget. Now, instead of budgeting for school fees, quality education, university fee, how do you save when you retire? You are now budgeting for, budgeting for health. When your daughter or your son or your mother or your spouse is sick, what you think about is, where will I get money? That should not be your first thinking. The first thinking should be, where can I get the best care? But now it is shifting to, money, which is really unfair to us, to citizens, and also to the people that we actually serve. So that means a family giving to choose between taking care and paying for other basic needs. So reducing inefficiencies expenditure, increasing sustainable domestic financing, and also reducing financial hardship are not simple technical PFM objectives. They are equity objectives. That the fundamental principle of health financing. Equity in healthcare service delivery. So this is a simple results chain. What I've been talking about, I've tried to summarize. We call it theory of change, because we are planners. You don't do things without arranging them in chronological order. What are the challenges that we have identified? So on the left-hand side, the challenges we have identified or recognized are fragmented financing, weak links between plans and budget, low domestic financing, weak budget execution, and insufficient transparency and accountability. So I will emphasize here budget execution. We want budget increase, but we want efficient budget and quality budget execution. So the challenge will be this year that we want to know, like the Permanent Secretary and the Director General sitting here, it will interest you to know how much is budgeted for you for 2026, how much is released to you, and how much you are able to actually spend. As a starting point. Then you will appreciate, So the next step will be, where did you spend that money? And after that, has your expenditure actually resulted in any positive impact? So we need to actually understand this process. So our starting point is the enabling foundation at the top, country ownership and political leadership. We cannot sustain PFM reforms without country leadership and political ownership. With strong health financing, planning collaboration, adequate capacity, reliable data, and coordinated partner support, countries can implement the priority reforms shown here. So this, if you look at it, I don't have much time now, but what it emphasizes is one plan, as I said earlier, one budget, one report, stronger budget formulation and execution, domestic resource mobilization, better expenditure management, and greater transparency. Health sector was not used to auditing before. 20 years ago, 30 years ago, for those that were in the field, will tell you that you do your implementation, you move on. You write your report, you move on. You have immunized this number of patients, children, you move on. Nobody comes to actually find out whether you have actually implemented. But now it is changing. Global Fund will change auditors, will send auditors. Gavi will send auditors. UNICEF will send auditors. WHO will send auditors. Africa CDC will send auditors. WAHO will send auditors. So it all boils down to what? Accountability and transparency. And the last but not the least is outcome. Your intervention, are they yielding the desired goal? So in all what have been said earlier, so how do we know that we are actually making progress in this journey? How will success look like? How do we know together as a team here in Western RCC know that we have succeeded? Not by the number of workshops conducted or reports produced, no. Success means higher budget execution for Director Generals and Permanent Secretaries here. One thing you will succeed end of this year is high budget execution. Approved health resources actually reaching implementation. And it means also higher quality expenditures, resources going to interventions that deliver the greatest value. As I keep emphasizing, every dollar spent should be accountable and should produce results. And it means credible budgets, timely fund flow, and transparent procurement, and not only that, expenditure tracking and stronger accountability. For the Lusaka agenda, success means stronger country ownership, better aligned external financing, and integrated primary healthcare, and increasingly sustainable domestic financing. So ultimately, success means countries increasing financing and managing resilient health systems through their own national institutions. So this is the transition from aid dependency towards health sovereignty. From aid dependency towards health sovereignty. Call to action. So I would like to conclude with 5 calls to action for our region. First is countries must own and champion these reforms that we are going to bring to you. Ministries of Health and Financing, and also Ministry of Finance, and other countries that have separate ministries of planning, and our partners must work around a common national priorities. And the third is, let us move from plan, one budget, and one report. Stronger execution and accountability. And the fourth is invest. We must mobilize more domestic resources, but equally important, use every available resources more efficient. And fifth is we must learn. Learning, we mean we must track expenditure and results, use evidence, and continuously also improve. This is where M&E is. So Africa CDC will partner, support, and also strengthen and help countries deliver this ultimate, reform agenda. But ultimately, sustainable transformation must be country-owned and country-led, as I said, and the time to act is now. So let me leave you with one message. Health sovereignty begins when our priorities, our budgets, our resources work together. And to deliver for our people. Let us fund better, spend smarter, and build stronger health system, stronger financing, stronger systems, stronger West Africa. Thank you. Merci. Obrigado.
Thank you, Gabriel. Reserve your questions. I think we'll ask it after the session that will follow after that. For now, I think we have the next presenter, that is Nebiu. But before he comes, you have seen the TOC, and I think Gabriel will guide going forward in compliance with the PFM and Lusaka agenda. Maybe we come up with 1, 2 priority interventions, or if you like, activities that would realize or help the region meet that need. Now, going forward, the next presenter, Nebiu, Dr. Nebiu, I saw him around. He can come over. I think he's come with his team. As she's coming, you can wave, please. Just wave to the team. Just wave, wherever you are. Okay, fine. Thank you. Over. So Nebiu will break down the knowledge hub, knowledge management, and anything, and perhaps 1, 2, 3 activity to help us going forward. Over to you.
You want no, the projection is, he doesn't have it. He has, when you do it. You want it, please? Someone can figure.
Okay. Good morning. We bring you greetings from Addis Ababa, Africa CDC HQ. Hope all is well on the western side. I know I'm seeing Dr. Habiba here, so she has already extended the greetings, I hope. My name is Nabiyu Dereja, so I lead the Knowledge Management Division in Africa CDC, and I'm the Editor-in-Chief for Africa CDC publications and the journal that we have, the Journal of Public Health in Africa. How many of you know the Journal of Public Health in Africa? Before I move on to my presentation, I need to catch your attention, you guys, huh? Hello? Am I communicating with the team here? Okay, so we have a journal that's serving the continent, so the continental public health. And I think I want to grab this opportunity because you are from mainly from public health institutes, and we encourage submissions from public health institutions, and also we need to support, they strengthen the capacity of you in terms of publishing scientific products that you are handling. Next slide, please. Okay. We always talk about evidence-informed decision-making. For evidence-informed decision-making, we need knowledge. And that knowledge is not only from research. Knowledge, research has knowledge, surveillance has knowledge, clinical practice has knowledge, community has knowledge, indigenous knowledge, and a lot of public health programs, interventions, all has knowledge. Evidence-based informed decision requires consolidation of all the sources of knowledge to reach into decision. So that's why we need to advocate for knowledge management. So for knowledge management, when we say knowledge management, I think this is also a concept which is not familiar in the public health arena. So I have to very simplify the concept. It's about three things: making knowledge available for decision, making knowledge accessible for decision, and supporting translation of knowledge into action. Those are the three elements when we speak about knowledge management: making knowledge available, making it accessible, and making it usable. Availability by itself has something. It's not like availability by itself might not influence accessibility. Available knowledge might not necessarily be accessible. There are a lot of knowledge which are available but not accessible for decision. At the same time, it's not only accessibility that can inform usability. There are available, then accessible, but not used for decisions or for practice and action. So how we can support that in our system? That's the interest of knowledge management. It's aligned with all the things that we are doing because it's about evidence, because it's about knowledge. It cut across every program, every agenda we have, AHSS, the Africa we want, and if there are any regional agenda that you have in the public health ecosystem, it aligns with it. Why? What is the rationale behind this exercise? The first one, we need a centralized platform where we can access all knowledge in public health. You are from National Public Health. Many of you are from National Public Health Institutes and Ministry of Health and partners. You produce a lot of knowledge in your departments. Am I right? Are we all together? I think let's be very interactive. Huh? I do also, you know, I have a background of academia, so I need, you know, people's active participation. I'm sorry if I'm bothering you guys. Huh? I know you are bosses, but since we are here for one thing, I have to deliver, you know, the agenda as well. So we produce a lot of policies. We produce a lot of guidelines. We do a lot of inter and after action reviews. We have a lot of interventions and so on. Where do we find all those documents? Are they accessible really? Can Ghana access documents produced in Nigeria? The Nigeria interaction review document is accessible. Is it accessible in a very friendly manner for Ghana or other member states that we have? I can say no. We need a system which can facilitate access to products, policies, guidelines, different scientific outputs, and so on. That's one of the agenda of knowledge management. We need to facilitate exchange of knowledge. That's the purpose of this regional coordination. So one country should learn from the other country. And also, it's not like one country from the other country. Within the country, there are a lot of regions, provinces. One province, one region should learn from the other region. How can we facilitate that? That's the agenda of knowledge management. And the third one is generation and translation of knowledge. So we need knowledge management to facilitate generation, translation of knowledge, evidence into policies and action. Knowledge is hidden in different things. We collect a lot of data in surveillance, IDSR, event-based surveillance, we name it. There are a lot of data just sitting in data repositories without making some insights, without predicting actions, without supporting early warning and so on. We know there are a lot of data sitting. How we can make those data available, accessible, and usable for decision making? That's the interest of exposing, or that's the interest of knowledge management. Let me give you some background. We think we do a lot of research. We think we do, just I'm speaking about Africa, we think we do a lot of things, scientific publications and so, but still Africa is the least in terms of these contributions. We are contributing about 3% of global health knowledge. And our share of global burden of diseases, how much? It's like 25%, approximately 25%, and we are, in terms of population, we are around 18% of the global population. But when it comes to the contribution we are making in global health ecosystem, in terms of research, in terms of knowledge generation, we are very underrepresented. And we were talking about global health architecture. It's a big agenda. Global health architecture, you need to change the narrative. And that's when you ingest knowledge, when you ingest your voices, the global architecture can be easily changed, or the narrative can be changed. Look at this line graph. It is showing the pattern of clinical trials over the last 2 decades. And the line next to the x-axis is Africa. And it looks like very flat, and it's not changing from time to time. I mean, at least the other regions are showing either the downward trend or the upward trend or whatever. If you see the African line, it's more or less flat, which means we are not showing any progress in terms of the clinical trial ecosystem, which we need to change in Africa. Next slide. This is not working. Next slide, please. So in terms of generation, we are lacking. What about making it accessible, huh? Not this one. KM June. Yes, this one. Next slide. In terms of the number of researchers we have as compared to other member states, Africa is the least. In terms of publication outputs, Africa is still the least. How we can change this ecosystem? I mean, since this is ReTAC, ReTAC is more of technical and scientific, I know that. So I'm not speaking with political people, I'm speaking with the technical, scientific people. And I want to challenge you guys. And it's up to us to change it. Yes, thank you. Up to us to change this ecosystem. I mean, we can't continue just always saying 3%, 5%, least represented. I mean, we need to change. It's up to us to change. It's a technical, scientific thing. This is speaking about the number of researchers per million population. You can see many of African countries, actually, they don't have data, but you can see or you can infer from the available data. We are the least from the global countries. And this has a consequence, obviously. If you are not investing in knowledge, if you are not investing in research, it has a consequence. One of the agenda we have is, one of the pillars of AHS's agenda is local manufacturing. We are dependent today, very heavily dependent. 95% of our vaccines, medicines are coming from abroad. And we need to change these dynamics. I mean, if we are going to intervene, or if you are, like we say, sovereignty, health security, I mean, we have a lot of big agenda. But the root challenge we have, the gap we have needs to be addressed if we are going to address the top impact. Sovereignty cannot be achieved if you are not manufacturing. If you are not conducting research, if you are not investing in research, you can't manufacture. It's easy. So you need to invest in research, to manufacture, and then to maintain our own sovereignty. That's the link. You can see there, huh? 575 manufacturing industries in Africa as a whole, compared to 10,000 in India and 5,000 in China. Those are, I know they are big countries, but it's still one country, but as compared to our African industry, we are very limited. And in Africa, there are only a few countries trying to invest somehow in R&D ecosystem. Egypt, South Africa, Algeria, Nigeria, and Morocco. And others are like cumulative. You can see the others on that line. So we need to change these dynamics. Publication, is the least. It's still, you can see from the map, Africa is the least in terms of contributing for the publication. So the landscape is very skewed. And see this. See this map. And I hope you can interpret from the map. You see, the bubbles represent the number of publications. And the diseases are highly prevalent in Europe. Am I right? Am I right? Are they highly prevalent in Europe, the diseases? Tuberculosis, malaria, HIV, Ebola. These are the diseases known to be highly common in Africa. Okay. The publications are concentrated where? They are concentrated in Europe. What is the implication of this? What's the implication of this map? The diseases are here, the samples are here, the data are here, the research is conducted here, but represented, affiliated for European countries. It has a lot of implications and a meaning, and I will leave that interpretation for you guys. But we are not doing very well. So, we have issue in terms of availing knowledge. We have issue in terms of making that knowledge accessible. And we have also a limitation in terms of translating available, accessible knowledge. Only 14% of available and accessible knowledge is translated in Africa. 86% not translated. Only 14%. And even when translation is there, it takes an average of 17 years for translation. How we can shorten this? That's the interest of knowledge management. We need to support the translation ecosystem as well, and we need to try to change that one. So, the landscape, the ministries, national public health institutes, they don't have knowledge translation unit. How many of you in your institution has knowledge translation unit or knowledge management unit? Can you show up your hands? How many of your entities, national public health institutes or Ministry of Health? I can say almost none. And when there is a unit or some structure, it is very under-resourced, understaffed, with fragmented operations, nothing there. But we almost speak about evidence-informed decision-making always. There is no coordinator, there is no person to coordinate all the ecosystem of evidence. So we need to change. These are some of the evidence we have. So in Africa, CDC, just to address this gap, we come up with knowledge management strategy that has 6 objectives. I have spoke about the objectives in one or another way. Availing knowledge, making it accessible, making it usable. Those are the 3 pillars. And these 6 can be merged in these 3 pillars. And then using digital technologies, because we have a lot of digital technologies, partnership, collaboration, because knowledge requires this kind of coordination and collaboration. Those are the objectives. I don't want to go to this framework. This is the end-to-end process for our knowledge management. We have a lot of knowledge source. As I said, research is one source. You have public health programs that you generate a lot of knowledge. You have surveillance that you generate a lot of knowledge. You have different guidelines, public health resource, lessons, indigenous knowledge, practices, and so on. How many of our indigenous knowledge are documented? Huh? How many? No, I can't. You know, what is the challenge of outbreaks particularly in the current outbreak? Huh? The Bundu Bugio or Bundu Bugio. In DRC, it's a community, is a central piece of the response, and at the same time, the mistrust and the issues related to community engagement has come out to be a very serious problem for the response. How are we documenting? How are we documenting each piece of our community engagement, the culture, the context, the social being? Because that has a direct implication for response. Those knowledge needs to be documented, packaged, synthesized, summarized, made accessible to inform decisions and response. That's a very simplified framework for our knowledge management. So as a solution, as one of the solutions, we have Knowledge Hub, which is a centralized platform. You can see our Africa Knowledge Hub that we are also trying to roll out in our member states as well. This is the K-Hub we have, the knowledge management system, the portal, the electronic system, and with 40 plus communities of practices with AI-powered tools to support the synthesis, summarization, and also with multi-language capabilities currently accessed by 185 countries globally. Almost every country globally can access, and we are seeing who is accessing as well, with more than 250,000 platform users in our platform, more than 1,000 knowledge products and dedicated section for emergencies. KM signups at the continental level. I see Nigeria and Ghana from the Western region. Other countries, they are not accessing or signing up very well. So I hope after today we will see some more access and sign up to Knowledge Hub. This map also is exciting. Huh? See the map. Oh, it's not okay. So, out of 250,000 individuals who accessed our continental knowledge hub, I said Africa Health Knowledge Hub, almost I can say half of them are from the United States of America. And then China, and then Brazil. I mean, our advocacy, our promotion, our things, our everything is relevant to the Africa. I know there are emergencies and everything which may attract the other global communities, but Africa has issues in terms of accessing the portal as well. So we need to change. I mean, we are trying to promote, but at the same time, our acquisition knowledge seeking has issues that we may need to change. So we are trying also to roll out in African countries the same system, knowledge management system, and we have started with around 10 countries. We have made some assessment, some leadership engagement to get buy-in and so on. And in Western region, we have engagement with Ghana and Nigeria. So we will be continue with other countries as well. And then we try to establish this knowledge management system in the Ministry of Health and National Public Health Institutes. Let me leave this for technical people. So it has 3 layers: the continental, regional, and then national level. National level will be for the national consumption, and then they will contribute to the regional, and then regional also contribute to the continental. This is the 3 tier model that we are following in the knowledge management. Usability has issues, so there is a need for making accessible knowledge to usable using different mechanisms, policy briefs, infographics, and so on. Cross-border knowledge exchange is critical, and this facilitates in COVID-19 mpox we saw in Marburg, in Rwanda. This is how Rwanda managed to initiate clinical trial for Marburg vaccine, which has actually contributed to the Marburg response in Tanzania and Ethiopia. Particularly for Ethiopia, it was first time, so almost everything, every practice that was implemented in Rwanda has shaped response in Ethiopia, and there are publications out of it. So this kind of cross-border collaboration, cross-border knowledge exchange needs to be promoted, and we need to institutionalize as well. So we can't do like one country by another country, and so if we have this ecosystem in general, the knowledge exchange ecosystem, all the institutional memories, all the response efforts can be kept there and then can last, you know, for generations to come. This is a publication between Rwanda and Ethiopian team speaking about the collaboration. So we need, at country level, advocacy, structure, and training is required. There are some governance documents that we developed at continental level, which can easily be customized at the local or national levels, and then we will be ready to support on that initiatives. So finally, every research, every knowledge, every public health practice should go beyond publication as well. So the goal is not publishing. The goal is not, you know, seeing our names in the journal. The goal is about impacting the public health, about impacting the betterment of public health. So that should be the goal. But publication by itself is not also something that we can ignore, because that's the point you start, like impacting, sharing, and so on. You remember, I'm finishing this final slide. We were in Namibia last year, and they had issues. I give you two examples. They have issues with hepatitis. And then, to respond to the hepatitis outbreak, they were very challenged, the Ministry of Health team, because there were no documented examples or documented response measures that they can refer. And then, finally, they were searching, and then they found something which is written like some long ago, hand by hand, and then it was stored within the ministry library or somewhere. And then they found it, and then they were fortunate to start from there, and then this is real kind of story that we hear from the team, from the ministry. And also, on the other hand, if you remember last year, there was outbreak of malaria as well in many Southern African countries. And at the same time, we heard that Egypt was certified malaria-free. 2024. Egypt certified malaria-free. We were struggling on the other part with the malaria outbreak. And then from Africa CDC side, we want to see how Egypt successfully eliminated malaria in their country. And then we want to conduct desk review, because we want to extract the lessons, and then we want to share with other African member states. Unfortunately, we didn't find adequate information about the elimination pathway. China, perfect. They documented the pathway. In Africa, we lack this. what if Egypt has, I'm not blaming Egypt, huh? Don't take it personal. So, what if Egypt has documented each and every step they followed for the elimination? It will inform Ethiopia, it will inform Namibia, it will inform Botswana and so on, who are struggling with malaria. That's what we are claiming today. You can't do that. There are a lot of things that you do, a lot of best experiences, a lot of lessons that you can share from your country to other country, and how we can make it, systematic, which can be documented for generations to come. It's not for you, for your coming generation, after 50 years, after 100 years. The same disease can appear after 100 years, and that generation after 100 years should not struggle from the scratch. You can keep memories, you can keep your response lessons, you can document everything, and that can pass through generations. So that's the call today for you to strengthen your knowledge management ecosystem. Thank you very much.
Thank you, Dr. Nebiu. You've heard, and I'm hoping that you are noting your questions, which will come after that. And we request you to remain in-house, maybe to respond to some of the questions that will come. Wami, I'm told you are online, but Dr. Habiba has requested to come in first. So just give a few minutes, and then, of course, you are next. So get ready after Dr. Habiba, Wami, Uche, then finally Modu. Over to you.
All right, good morning again, everyone. Excuse me for changing the agenda a little bit. I've been called for a meeting, but my presentation will be very brief, I promise. So I do not have slides, but I'll be discussing with you the data sharing agreements that are being signed by Africa CDC and our member states. Before I start this presentation, some of you have asked me about my presentation of yesterday on the rules of procedure of ReTAC. So while I don't have much time to present on them again today, I'll be more than happy to address any questions you have later on. I'll be available throughout the day. But also, I'll be happy to share with you the rules of procedure, especially for those of us who are new to ReTAC. That being said, today's topic is of a different nature. I'm here to discuss with you what we call data sharing agreements, what they mean, what they entail, and how we actually engage our member states. My role will focus mostly on procedures, the legal aspects, and not necessarily the technicalities of how we store data, as that's not my expertise. Notwithstanding, I can and will explain certain provisions, and if not, I can always revert in due course after consulting the relevant experts. Before turning to the content of data sharing agreements itself, allow me to briefly explain how it came about and what is intended to achieve. The DSA was developed, well, it started to be developed by Africa CDC, acting on its mandate as per the Africa CDC statute. Why we developed this agreement is to strengthen our collaboration among member states in preventing, detecting, and responding to public health threats. Therefore, the work does not rest on institutional initiative alone. It is also used to define the legal basis of where we stand on our relationship with our member states. So we operationalized this agreement based on Article 5 of the Africa CDC statute, and I will read it to you if you allow me. So Article 5.3 of the statute describes Africa CDC as an Africa-owned, value-adding, and highly credible institution operating in coordination with the regional coordinating centers in pursuit of its strategic objectives. Within that framework, the statute requires that Africa CDC facilitates easy access to critical information. So we do that by establishing a continental framework for data sharing, hence the data sharing agreements. We aim to improve data quality, and we develop data elements that prepare countries to adequately respond to disease threats, emergencies, and pandemics. We also assist in disseminating critical information to member states in a timely manner. So what the data sharing agreements actually do is respond to fragmented information sharing practices that we have at the moment. And to fill that lacuna, we aim to establish a common legal mechanism and system that enable member states and Africa CDC to exchange public health data in a trustworthy manner. So with regards to the purpose of data sharing agreements, member states basically share public health related information, like I said, to enable Africa CDC to carry out its mandate in pursuant to Africa CDC statute. We rely on accurate and timely data, and then we also inform on our behalf our member states of any updates or urgent updates for their action. So how does this exchange actually happen? What is the exchange architecture? So all data is exchanged at the national level, excuse me, and it's usually through an authorized institution designated by the member states. It means that you or your member state determines which national institution is responsible for sharing the data, and only that authorized institution shares the data with Africa CDC. Then, regarding the frequency, there are different levels as to the frequency of updating Africa CDC on information from your member states, and this depends on the category of data that we have as well. So for urgent or diseases under the International Health Regulation of 2005, the reporting shall be done within 24 hours of detection. Once an outbreak is detected and reported, we continue then sharing, well, member states continue sharing the updates with Africa CDC on a daily basis. For other data, so not necessarily urgent diseases, for example, the Ebola at the moment would require urgent and daily reporting. However, for other data, the agreement provides that it shall be shared within a period of 3 to 6 months. Now, there are different types of data that the agreement actually stipulates for. I will not necessarily go into the details of each one due to the time I have, but I'll be happy to discuss them with you later on. But just briefly, we have surveillance data, which means cases, deaths, recoveries, and contacts traced, locations, the date associated with reporting, symptoms onset and confirmation, among others. We have laboratory data, which is aggregated tested information, including the number of tests conducted, pathogens, and assays used. We have emergency preparedness and response, which covers both what a country has in place before a crisis and what it does during one. We have policy, health, diplomacy, and communication, which covers health systems, population indicators, so this includes life expectancy, maternal and child mortality, vaccination coverage, among others. We have research data, covers the size, distribution, and competencies of the public health workforce as well. We have safety surveillance and any other data relevant to the agreement. So how does, this is my part actually, how does this process actually entail? So not necessarily the technicalities. The DSA went through 3 to 4 or 5 main initiations, right? Phases. The first phase was drafting the DSA. It began with discussing with our different divisions and what needs to be included in the data sharing agreement. And this involved most or all divisions of Africa CDC. However, CDC does not operate alone, and we always consult our member states. So the draft was transmitted to each and every member state, and we received feedback, including the terms that member states would agree to, the concerns raised, and that the agreement should reflect a consultative process rather than a unilateral process by Africa CDC. I'm happy to report that we've actually engaged with all 55 member states of the African Union, and we have copies of the DSA in all of AU languages, so English, Arabic, French, Portuguese, Spanish. I think the only language missing is Kiswahili, but we'll be working on that. We also hold advocacy meetings. So similar to this one, we always like to talk about the DSA and its process and where it is at the moment. And we try to move forward with implementation. So this is basically the process within CDC so far. At the moment, we have We started this process in 2023. Until now, we have 9 member state signatories. From Western Africa, we have 3, namely Ghana, Nigeria, and Liberia. But we do have 2 member states in the pipeline, including Sierra Leone. That being said, from 2023 until now, I've said we had only 9 member states out of 55. So the process does face some challenges. The first challenge relates to transmission and follow-up. So in some cases, delays arise as to who we talk to from the member states involved. And also, CDC faces challenges in addressing the appropriate national authorities for consideration of the data sharing agreements and taking it forward. The third challenge relates to coordination. Well, the second challenge relates to coordination. In several cases, the absence, like I said, of a focal person makes it very difficult, which is why I'm actually here today to request your assistance, since you're the experts, on transmitting copies of the DSA to your member states. And the legal office stands available to assist in any legal matter, but we also engage with all the divisions that are expertise on the topic that would also engage with the member states moving forward. You can also, if not me, you can always engage with the Regional Coordinating Center. They'll be happy to engage in any questions you have on the DSA. I will be available, like I said today, to discuss with you the DSA, the certain provisions that might come in or might be of interest to you, including how we transfer data, the confidentiality, the binding nature of the agreements, and who from the ministry actually should be involved with Africa CDC. So please feel free to ask any questions. This sums up my time. I think Mudu has given me 5 minutes. I've taken beyond the 5 minutes. Yes? And I'll be running for a meeting, but please do approach me later on if you have any questions on data sharing agreements. Thank you.
Thank you, Dr. Abiba. Now, I think next presentation we have on FEM and FIOC. And you can bring in Wami. Is he Dr. Wami?
Okay, thank you very much. Let me try to share my.
Being asked as we prepare. Is he ready? Okay, fine. I think he's coming in a few minutes. Okay. So, Wami, over to you.
All right, thank you. I want to stay on existing protocols to be safe from exempting anyone. But I do recognize that we have. I do recognize that we have very high-level representation
Well, maybe you can hold on a bit. I think we have a challenge of the sound being set. It's okay? Okay, fine. Please go ahead. Wami, go ahead.
Okay, so I do recognize that we have very senior representation from our 15 member states in the West African region, and number of senior colleagues, partner. Kindly let me know once we are sorted.
I think you are good now. You can go ahead.
All right. Okay. So without much ado, I'm Wami. I work in the emergency program of the Africa CDC. I lead the country support program around capacities, learning and simulation exercises. I will share with you one of our program areas, what we are doing with you as our member states, and that's the public health emergency operation centers. Kindly confirm once we are sorted, please. With the sound, I think it's still echoing. Colleagues in the room, please can you confirm the sound is okay?
Yes, we can.
All right. So I'll be speaking about an agenda that has a story behind it. And it's around what the next frontier for emergency operation centers will be, working together with both our partners and primarily our member states. And when we talk of EOCs, whether hosted within National Institute of Public Health, both broadly ministries of health. Their evolution. I'm still getting a lot of. Is that the case in the room?
Want me proceed?
If the sound is okay in the room, I can manage, but I still hear the echo.
Wami, on our side, I think we are okay. Just check whether it's could be on your side.
As long as it's okay on your side, I think I'll manage.
Please proceed.
Let's proceed.
Please proceed.
Let's proceed. Yeah. So the very painful reminder of the 2016 Ebola also provided an opportunity for some positive. Many of them influence global health security. Changes or improvement in how we assess IHR capacities, but also how structures built and sustained. So we saw increased investment in public health emergency operation centers. And as of today, all of the countries actually in West Africa do have EOC. At least established. When we get to functional, fully functional, that might be some conversation to have and require some focus and investment to get these platforms working more optimally. So today I'll be introducing what we have called version 2.0 of PHEOC. And that is really moving us, helping us about not only existence of PHEOC, pushing us to where we are having optimal performance of the EOC, and really providing that coordination platform that prepare, to better respond and recover from
So I'll
emerging.
share briefly why this is
So
important.
I'll share briefly why this is
and where we are
important,
coming from,
and where we are coming from, and then a bit of the agenda.
So just to re-echo that point,
the point I've made before,
PHEOCs have been recognized as one of the several tools
now available to health systems
to improve emergency management.
And when we say management, it includes the whole spectrum of things that need to happen from when you want to prevent, outrightly mitigate, respond, and recover.
Within that,
several number of tools that are available to us.
Specific role is
to serve as a nerve center for coordination and decision making around information
and resource
for emergency in emergency context.
So, and this also aligns, of course, with the health security frameworks,
both at the global level and the continental priorities that we set for ourselves.
And to get us on the same page,
it's always good to re-echo what
that when we say an EOC is functional,
or what we expect by functionality of an EOC,
the four pillars
which
an EOC
should stand
are strong enough. So one pillar
is around documents.
There is a whole policy,
maybe
the Establishment Act, where EOC function and scope.
We've seen this in NPHI Establishment Act
as declaration
by ministers. We've seen it as gazetted in national documents.
It just has to be a document, national system, where the authority of the PHEOC and the institutional anchorage, whether to an MPHI or to ministry or a standalone, is clearly
and then down the ladder you have more operational documents that help the EOC to run the day-to-day readiness and response functions.
The second pillar is
the data and information.
Some of you are using the DHIS tool. That's great. EIDSR, and several of the other platforms that exist. Whatever that choice is, we have to make sure that it's comprehensive enough to cover the components of what an EOC should. What gets us ready, and what in response and how we document our recovery mechanism. Then, of course, what is usually more infrastructure. So we want to see that strengthened, and it's also, of course, the third pillar within the four that we expect when we see an EOC is established and functional. To run or to piece things together will always be the workforce, the human capital. Investing in skilled and trained personnel, the requirements to have a functional. I spent time to describe this just to make we understand, and we can reflect back in my country. Do I have a physical facility with the computers, the screens, dashboard, and several of the other IT and tech support systems? Do we have any document anywhere that gives the authority to be what it is called? Of course, the data system. Because you have a physical structure and you have everything without data going into that room you call EOC, processed and turned out as information for discussion and action. You probably just have another meeting and EOC. So data and information is the bedrock of an EOC. And the more comprehensive that data and information a process is,
the more you are intelligent, the system is intelligent
in terms of
identifying and responding to risk a lot earlier.
Okay.
Okay.
On the next slide here,
on the next slide here is to share with
this
you
conversation
that this
has
conversation has gone to the highest
possible.
level possible.
And as Africans, we are very proud to say
this is the
this
first time anywhere in the
where
world
EOC,
where
PhD
PhD
is caused by heads of state. And this happened in Lusaka 2022, on the sidelines of the fourth mid-year
meeting,
coordination meeting, hosted by the president of Zambia, the chairperson of the AUC at the time, and then the chairperson of the AU. At the time, it was the president of Senegal, and his colleagues
and representations from other countries were in that room
only one agenda
with only one agenda on the table, and that was PHEOC.
This was recognizing that
EOC had played a strong role over the years
in how emergencies are managed.
It has emerged as one of the best practices.
Member states should
recognize
and add
this
it to the
and add it to the tools that are available for preparedness and response on the continent
as it concerns
health security.
We translated that
less than a year later
into
continental strategic plan. And the target was
to see in 5 years
member states strong on the four pillars. So you see the 1990 across four, and then a fifth pillar which is around
having up to 5 member states
who have demonstrated capacity and can serve as our centers of excellence.
This is work in progress.
And we're really proud to note the
commendable efforts
all
of our member states
have put into the journey,
and we continue to
support as we see subsequently in the slides.
So infrastructure,
I think one of our taking that advocacy
to our partners and our member states,
we were able to secure funding from our colleagues in
AFDB,
African Development Bank,
and that served us 23 member states.
And I think for
West Africa, we did have around 8 member states benefiting. Of course, the resources
we want to see all the member states benefit
but the resources
were limited, and we had to draw up some priority targets, hoping that that's only if it's one, and we'll continue to further through other mechanisms and partnerships that continue to come on board.
As I had highlighted before, there's also the documents
As a continent and
member states
partners and member states have validated documents, a number of them in terms of counts, around 50,
but they serve
various functions within
EOC,
how to manage EOC
readiness,
how to coordinate readiness, and how to coordinate response.
Those are available
both to our colleagues from the regional office and of course the member states technical experts that work within PHEOCs.
Information systems opportunities, we've provided quite a number of training, installations based on what the member states prefers as the option.
We do have IFEM, SITA-aware Nigerians from the Nigerian team,
EMS,
DHIS2, and several others.
Whatever choice to make sure it is
and it is used
for decision making.
Investing in the human capital is the other piece. And as of today, we have a count of more than 40 member states that have benefited from various sort of kinds of trainings, short trainings. The latest introduction is an advanced FEM fellowship. We are proud also to know that colleagues from National Public Health Ministries of Health West Africa have benefited from this training and will continue to benefit, of course, as part of the continent. So, having described where we have come from, what lies ahead of us in terms of priorities, this is what we now call the 2.0 agenda, version 2.0, and it touches on seven areas. The first is we do recognize the progress made around EOCs. However, that progress is not comprehensive and is not complete. So the very first thing is accelerate the establishment targets. Let's accelerate the establishment targets. Let's have EOCs. Let's close that loop. Whichever country does not already have an EOC is already lagging behind. Utilizing a tool or a platform that has been demonstrated over and over that it's a good addition or it's a credible addition to our system for readiness and for response. The second agenda is to redefine functionality means around outcomes. You can already see that our functionality definition is largely on: do you have all the documents? Do you have the workforce trained? Do you have the information systems? Do you have the physical structure? That is primal, and it will always remain important and critical. But we need to move a notch further and start looking at what does this mean? What does this mean for better preparedness and ultimately for saving lives, reducing the number of cases, reducing the number of deaths from public health emergencies. Those are the things we need to see. Do we have the resources that are accessible and readily accessible? Are we able to deploy faster? Are we able to make decisions faster? Those elements become the real frontier of what the value of EOC represents for health security. The third pillar is decentralizing operational capabilities. We're always impressed to note that a number of our member states do not only have national PHUs, but have gone to establish subnational EOs. This is what we want to see. Emergencies, as we know, will always start and end in the communities, in the front lines. So the more we push these capacities closer to where emergencies will start, they better for all of us. We want to start seeing by this item more subnational opportunities for mobile EOCs, and also opportunities for virtual EOCs as needed. The fourth pillar is the expansion of the intelligence horizon for PHEOCs. It has almost become a norm or the easier option to stay with case counts and the number of deaths strictly within the epidemiological characteristics of an outbreak. But we want the EOCs, and we've collectively agreed that EOCs can do a lot more. Can we begin to integrate climatic
environmental data, water sampling and the other risks that we can assess, zoonotic data, mobility data, conflict and other intelligence that will be useful to proactively predict and take actions around emergencies long before they
So intelligence
happen.
is
So
one very
intelligence
important
is
thing
one very
that we
important
want to
thing
see the
that we want to see the
evolve into.
EOCs evolve into.
The fifth pillar is
The fifth pillar is the
connecting PHEOCs.
connecting PHEOCs,
And that speaks to
and that speaks to
strengthening what is already
strengthening
existing.
what is already
So
existing.
first, the EOCs
So
need to
first,
stand,
the EOCs need to stand,
and they need to be functional.
and they need to be
The next
functional.
bit is
The
that
next bit is that
operationally, not just on papers,
operationally,
we are seeing that
we are seeing that EOCs are
the national
connected to be the national
very
to
strong connection,
very
with
strong
subnational.
connection with subnational.
But on top of that, this meeting
EOC
is held in Accra. So
EOC in Ghana
can be connected to its
can be
neighbor,
connected to its
Togo,
neighbor,
Togo,
to its
Ivory
neighbor,
Coast,
Ivory
Sierra
Coast,
Leone,
Sierra Leone, Liberia,
Guinea, and
as far as Cape Verde,
and the
and
whole region. So
the
we
whole
really
region.
want to
So
see
we
that
really want to see
connection.
that connection.
Operationally,
on day-to-day basis
across EOCs,
across EOCs, and of course that network should translate into
a better picture for
the continental EOC that you all contribute to.
Then the sixth pillar is strengthening the national FEM system, which speaks to the workforce development, having training programs. So we want to move away from a partner determined training and intermittent training opportunities. We want to start seeing that each of us as a country has a training program, and predictable. People can come in, benefit from it. It has a budget, and then of course the partners can always come to augment. So having training programs around how the EOCs can be best used is very critical. And then, of course, establishing common standard and trusted cross-border exchange and support. Then the seventh is strengthening of guidance, evidence and research. My colleague from the knowledge management has spoken about what we are doing as an institution to work with all of you and partners to strengthen the evidence base for what we do in Africa. And that does not exclude the PHEOC. We really encourage that we start seeing a lot more of publications, but very intentionally sharing those experiences and being able to shape the next level of policies, implementation within the continent and globally. So this is where I'll stop. With the last bit being that to implement these seven shifts, what we envision is that there will be regional networks. We are in communication with the technical colleagues in your member states to see how through the regional office to establish regional network for FIOC. We also have plans to get the twinning program running, where one country which is in some area of the EOC can connect with another country, share experience. Sometimes it will involve traveling, but a lot of times it will be virtual. But really having that operational connections between countries will be a value addition to how we envision the operationalization of these shifts that we are proposing. So with this, success for us will mean we have faster activation, trusted information and accountability, coordination mechanism within West Africa as a region and collectively across Africa. Thank you very much. Thank you very much. I'll be on standby to respond any questions or comments that might emerge. Thank you, and over to you, moderator.
Thank you very much, Wami. Just by your word, please remain standby. Even after tea, we will still hope you are there to be able to respond to those questions. Now, the next presentation we have is on AMR governance, and this would be Prof. Uche. Hopefully, you'll also take minimal time. Then, of course, we conclude with the module on PHC outcomes. Over to you, Prof.
Apologies for standing between you and morning tea. So I'll try and make this really very quick. The slides, please. Slides? Okay. So while we're waiting for the slides, good morning. I would like to thank Dr. Koku and his team at the West African Regional Coordinating Center for the invitation to be part of this ReTAC meeting. My name is Dr. Uche Chukwungwaba. I'm an associate professor of global health law at the Lincoln Alexander School of Law, Toronto Metropolitan University in Canada, and also the program lead of the Regional Health Governance Study, which is based at Toronto Metropolitan University. In the next few minutes, I'd like to present on two key projects involving the collaboration between the Regional Health Governance Study and the West African Regional Coordinating Center of Africa, CDC. The first is a Catalyst Grant project on AMR governance in Africa, in West Africa. And the second is an ongoing project proposal, which we are putting together in respect of an EU Global Health EDCT P3 proposal, which we're developing with Africa CDC and other collaborating partners. And then I will conclude with a call for action by identifying how member states can work with us in respect of these two projects. Now, the Catalyst Grant is a project that is funded by the Canadian Institute of Health Research under a Partnering for Impact Award, totaling 150,000 Canadian dollars, running into 12 months from May 2029 to April 2020, from May 2026 to April 2027. It was designed as a genuine tripartite partnership rather than an academic study, with consultees involving West Africa Regional Coordinating Center of Africa CDC as principal knowledge user, Social Capital has knowledge user, and the Regional Health Governance Study at TMU serving as the academic lead and nominated principal applicants. The project involves 3 phases of work involving mixed methods across all 15 member states of West Africa, with accounts for communicating output in English, French, and Portuguese. The framing for the project comes directly from West Africa Regional Coordinating Center's Abuja review, which took place recently. The goal of the project is not to advance new regional frameworks on AMR, but to support member states in updating and implementing the national AMR policies they already have in place. Everything that follows is in service of that objective. 3 guiding questions structure the whole project, and they map directly onto 3 aims of the project. The first is, what support already exists for consistent AMR policy integration within West Africa? Secondly, what roadblocks impede effective and consistent implementation and coordination across the region? And thirdly, what imperatives are needed to design a regional implementation framework championed by the West Africa Regional Coordinating Center and embedded within member states. The work runs in 3 phases: the completed environmental scan and stakeholder mapping. The second is the virtual consultation phase that needs ethics approval, and for that we will be reaching out to member states for their designated focal points to secure ethics approval within your respective regions. And then the final phase, or the third phase, is a convening in October or November in Abuja, where the community of practice that we hope to emerge from this project will launch. Knowledge mobilization is not a phase. It runs throughout the entire project and involves, different channels for communicating the research, involving radio broadcasts, publications on partner websites, social media outputs, and policy briefs which will come out of each phase of the research. Now, our initial findings from the completed first phase of the project, in that process, in the initial findings, we interacted with 175 records and extracted 88 against a structured form. And the initial findings are quite encouraging. The region we have found does not have a policy-making problem. Frameworks exist on the continent. What is still being built is the machinery for implementation and measurement, a far more tractable challenge than starting from nothing. On what is working, the enabler evidence is clear. Liaison and coordination systems appear in 55% of records we have examined, the single most cited enabler in the review. That is a direct endorsement of the coordinating role of West Africa Regional Coordinating Center and the strongest evidence base for the community of practice that this project intends to launch. External technical and donor partnership follows at 40%, showing that the region attracts and absorbs support effectively. Political leadership stands at 31% and community engagement at 20%, are both areas where this body is well positioned to add momentum. The success stories demand mentioning. Côte d'Ivoire's repeat remap exercise tracked implementation from 5% in 2019 to 70% by mid-2022 because measurement was institutionalized. Senegal's IPC has also shown some very positive outcomes. The constraints on screen are minor image, a mirror image. For example, we have data systems and awareness, enforcement, and financing. 2 are directly actionable here. Only 9 of 88 records reference the Africa CDC AMR framework. Most are citing WHO's GAP or IHR instead. A visibility opportunity for the continental framework is therefore evident, and it's a clear role for West Africa Regional Coordinating Center. And 42% specify no indicators. Where states set them, progress then becomes measurable. Our environmental scan and stakeholder map is a project that has run alongside this work we are doing. The environmental scan covers national policies, action plans, and regulatory instruments across the 15 member states, with monitoring and evaluation status recorded country by country and produced in all 3 working languages so that states can verify the entries against their names. We would welcome verifications from member states during the virtual consultation exercise in phase 2. The stakeholder map covers ministries, laboratories, regulators, professional bodies, and civil society, and is how we identify the focal points who would anchor phase 2 of the project. Both culminate in a policy brief for the tripartite partnership to publish, and that will constitute our first joint publication in the project. Where we are right now, we are at the point where we are trying to secure ethics approval for phase 2, the virtual consultation, and this is where we need your support. Phase 2 comprises stratified focus groups and key informants interview with AMR focal points across member states, professional councils, providers, and civil society organizations. As with any research of this kind, it begins once ethics clearance is in place at each participating institution. Today, we have submitted an ethics application to the host institution, Toronto Metropolitan University, and we're engaging with that process to finalize and secure ethics approval. With Africa CDC, West Africa Regional Coordinating Center, we are constructively engaging on securing ethics approval across member states that are involved with this, that are implicated by this research. That is the 15 member states. The remaining piece is your institutions. If each representative could point us to the colleague who handles ethics approval in your respective countries, a name or an email address is enough, we can begin the conversation straight away. Ethics processes are necessarily sequential, so an early introduction protects the plan to host an in-person meeting in October or November in Abuja when phase 3 kicks off. And it is in phase 3 that we will launch the community of practice. I have circulated some documents with Sam, who will make it available to member state reps, where you can sort of indicate who we can contact within your respective countries to process ethics approval. Now, this leads me to the second item that I'm presenting on, and this is a different project. It's an ongoing proposal, which we are working with the West Africa's Regional Coordinating Center of Africa CDC, and it is in respect of an European Union Global Health EDCTP3 Coordinating and Support Action Project Topic 2. We are preparing a proposal with the West African Regional Coordinating Center as the scientific project lead, and the deadline for submission, the internal deadline we have set for ourselves is August 31. The project deadline is September 2. We've been working on this proposal with the West African Regional Coordinating Center for the past 3 months, and we are at the tail end of finalizing that proposal. The purpose of this interaction is to bring member states up to speed with this project and to also secure your input or buy-in. Topic 2, now, topic 2 is enhancing integrated research and healthcare in sub-Saharan Africa through digital innovation. Sorry, I think. Topic 2 is enhancing integrated research and healthcare in sub-Saharan Africa through digital innovation and AI, and it sits in the 2026 program of the EU with an indicative budget of 18 million euros, expected to fund around 8 projects at roughly 2.25 million euros. So, in other words, the proposal we are making is for a 2.25 million euro grant. 2 practical points are notable. It is a coordination and support action funded as a lump sum at 100% of eligible costs, so there is no co-funding requirement on partner institutions, and that matters for your participation. And the deadline, as I've indicated, is 2nd of September, and a single stage, so we are submitting a full proposal. One feature plays very much to this region's strengths. This call favors better use of what already exists over building new technology. Its 3 pillars are strengthening systems and capacity around existing records with low-risk AI, demonstrating scale-up of validated technologies nationally or subnationally or nationally or sub-regionally. And 3, improving coordination between countries. It also looks for strong African institutional leadership, Franco and Lusophone participation, and alignment with WHO, Afro, and Africa CDC strategies, which describes what the regional coordinating centers' existing mandates attempt to do. The gaps we're responding to here in West Africa has made real documented progress in surveillance and regional coordination. That is our starting point. And the proposal says so plainly. Building on this starting point, 4 areas will benefit from support. The first is interoperability. Clinic, hospitals, and ministry systems do not yet fully communicate with each other. Data use. Valuable data is collected that has not yet become regional decision evidence. Continuous monitoring. Governance measures are implemented without a standing mechanism to assess effectiveness and equity. And finally, infrastructure realities. With 60 to 65% of West Africans lacking internet access, individual record linkage is impractical, which is exactly why we designed a population-level federated approach that works with conditions as they are. DHIS2 is already deployed across virtually all your countries with the WHO OOAS warehouse and Eco Alert alongside. The opportunity is to strengthen that backbone. We propose the West African Health, Governance, and Decision Support Hub as the key proposal from this research. This is a federated, sovereignty-preserving decision support layer. It helps member states make better decisions with data they already collect in their countries and tracks governance measures over time, which is the gap that we pointed to in the Catalyst Grant project I presented a bit on earlier on. What this is not about, this project is not a data collection tool or parallel reporting system. This proposal does not replace DHIS2, the WAHO or OOAS warehouse, or Eco Alert. It depends on them. It does not move data sovereignty away from member states. No individual identifiers and country-specific agreements will be in place based on the presentation you've heard about the DSA. And AI is bounded to 4 support functions, complementing your epidemiologists rather than substituting for their judgments. 5 objectives aligned to the call from the proposal we are working on. There are 5 objectives that we have written into the proposal. 1 is to establish the hub as a regional decision support layer. The second is to deploy low-risk population-level AI across 4 bounded functions: data quality validation, outbreak detection, forecasting and prioritization with data quality first in sequence. 3, build the federated legal framework with country-specific agreements and an AI governance and equity committee that also satisfies the buyer's audit requirement. 4, strengthen coordination through dashboards and briefs routed through processes that the West African Regional Coordinating Center already runs. And 5, build local capacity and AI literacy, which is how the benefits from this project will outlast the grant. The grant is a 5-year grant. Intervention pathways and expected outcomes. The theory of change is the basis that is the theory that anchors this project. Context and gaps addressed by the hub flowing through the 3 clusters into dashboards and briefs that are routed through the West African Regional Coordinating Center's existing coordination processes rather than sitting on a shelf. That routing turns evidence into decisions. 3 horizons follow immediately, ending in strengthened interoperable regional health governance across West Africa. The 5 phases that I've flagged run from diagnosis to institutionalization, each with a defined deliverable. Phase 1 maps existing DHIS2, EMR, and IDSR systems and the legal relationships across the 15 states of West Africa. Phase 2 establishes governance. West Africa Regional Coordinating Center is confirmed as owner and a liaison task force to progress data sharing agreements. 3 states to date have signed, as we know, so there is a clear room to build momentum in this area. Phase 3 runs the clusters in parallel to assess data quality, standardize them, and then apply AI only through agreed thresholds. Phase 4 routes outputs through the regional coordinating centers processes, and phase 5 transitions hosting into member states' co-ownership at the end of the project. There are 3 technical clusters that would form the basis of the project. They are the AI and technology cluster that will drive the 4 decision points. The legal governance cluster develops the evaluation framework and acceptable AI use policy and equity standards, which I've mentioned. And then the implementation cluster designs the integration architecture and country rollout with dedicated Francophone expertise and Lusophone expertise built into the project. Now, who are those part of this consortium for the project? There are 4 key members of the consortium. The West African Regional Coordinating Center, through Dr. Koku, the project scientific lead and formal owners of the hub. And ownership of the hub will sit within the region, and this is by design. The second is the Regional Health Governance Study, which I lead. We would anchor the legal governance framework carrying the administrative load of the EU application. And we have social capital, which will handle strategic alignments and anchors a vast network of West African consultancies. And finally, we have MERIC, an EU member state partner that is required under the call. Your role for phase 1, we are asking for a national focal point to the Africa CDC hosted task force, a completion of the pilot country selection questionnaire, which I have circulated, progress on a country-specific data sharing agreement with Africa CDC, confirmation that your DHIS2, EMR, and IDSR systems can support the landscape assessment. In return, you will get a federated decision support layer that plugs into what you already run, AI-enabled support for surveillance and forecasting, dashboards in English, French, and Portuguese, capacity building for your staff, and a standing route for national evidence to shape regional policy. Endorsement of this proposal means a letter of support on West Africa Regional Coordinating Center letterhead, signed by member states, countersigned by member states, progress toward signing onto the DSA before phase 2, a named liaison, adherence to our AI acceptable use policy, and over time, integrating the hub into your Ministry of Health budgets. To be clear, no individual level data will leave your country. Sovereignty is preserved throughout the process. Pilot countries that are selected for the project will only take on earlier work, and other countries will join by the time we get to phase 5. The live question before us is the selection of the pilot countries. We have identified hepatitis B as the illustrative use framework for the proposal. Readiness signals that your DHIS2 is matured EMR and IDSL coverage are well established. Data protection agreements are in place. And also we have the focal point leads for the projects. What we ask of member states are, first, we are gathering contact details for member states representatives to support phase 2 and 3 of the Catalyst Grant project, which I presented on earlier. Second, and most time sensitive, an introduction to a colleague responsible for ethics approval at each representative country, so that we can begin early and keep timeline comfortable for everyone. And third, in respect of this proposal, please look out for the pilot country selection questionnaire, which will be circulated to member states, so that the project team can be able to make an informed decision on the pilot countries that would anchor this project. Thank you.
Thanks, Prof, for the great presentation. I think at this juncture, I want to push the next presentation to and all questions until after tea. But before we go for tea, I'm informed we have a guest amidst us, or is here to join us. Maybe I'll ask Modu for the guidance on that. Modu.
Yeah, thank you very much. We have been told that we have an important guest here. That's the Deputy Minister of Health, Dr. Grace, will be coming to say 1 or 2 words, and we have a photo with her. And then I got the permission from about Dr. Koku and then Prof. Aliko that she can come in and then just make 1 or 2 words. And then from there, then we can be able to go out. Prof, Walter, can you reach out to Prof. Aliko? I just send, check whether he's around that we are waiting. Yeah, he should be around that area. He's not far. Yeah, or you can call him and then so that we are ready. So as he said, we are going to have tea break, 15 minutes. The 15 minutes break we are going to make it so quick so that when we come back, we have questions for 10 minutes and then I will save my presentation till later. Then we have a panel session. We'll start with Dr. Mariam's panel session, and then also we have Dr. Elfas. And then we can close, then from there we go into the other election details. Maybe I'll do a presentation before the election details, and then from there. So that is where we are. We are waiting for Prof. Aliko to come in to bring in the Deputy Minister. Is he coming? He's coming. So we just allow the Deputy Minister to come, and then perhaps she might not be able, but she can just come straight here and say 1 or 2 words. Yeah. Can come straight here. Okay. Dr. Grace, you can just come here and then for a few minutes. Welcome. Thank you.
I'll take 1 minute.
No, more than
Hi, everyone. Thank you and welcome to Ghana. This is just a drive-by. So I'm just driving by to see how you're doing. I hope everything is going well. After this, please make sure you enjoy Accra. And also make sure you eat the proper jollof so that we don't have any jollof wars. I'm Grace Ayensu Dankwa, Deputy Minister of Health. I'm also a surgeon specialist, trained in the US, but I'm now in Ghana, fully licensed in Ghana. I'm the Deputy Minister of Health, like you said. I'm also working with African CDC, so I'm very close to your organization. I'm on the secretariat for the ministerial high-level committee, changing the global architecture, and I'm part of the secretariat in terms of health sovereignty and in terms of some of the things we have to do to have our own African solutions to African problems and be health sovereign. So I'm working very closely with DG and the team, Dr. Benjamin, and a lot of people from African CDC. I know my minister was here yesterday. Currently, what I do most is working on maternal mortality because it's our worst performing health index. And I'm trying to reduce it by 20% every year. And we have started looking at the architecture, going around the entire country, looking at what is really on the ground, what the CHIPS compound looks like, what the health centers, down to the very last mile and to the remotest clinic, to see what the issues are, so that when we resolve it, we can resolve it comprehensively and build into it quality control and quality assurance, so that one part of the country, the discrepancy or disparities between the regions are also huge. Even sometimes within the same districts, that health disparities are huge. So the idea is to bridge that disparity by building into it quality control and quality assurance. So me in the Western region, I'll get the same type of maternal care as the person who lives in Accra. Incidentally, I'm also the Member of Parliament for Esikadu Keten constituency in the Western region. So I wear two hats, and thank you. And I don't know what else to say. They gave me 2 minutes. I think my 2 minutes is up. Enjoy the rest of your day.
Thank you very much. Honorable, you can have a picture with Dr. Koku and then Prof. Aliko in the middle. And then, colleagues, let's get a good picture of, and then, partner, Ignatius, ReTAC chair, you can join. Say, good. Let's have a... You got it? I hope your cameras are taking good picture. We need it for the archives. Okay. Thank you very much. Okay, another one. Okay. Good. Are we good? Perfect. Let's give a round of applause for visiting. Honorable, thank you so much for coming. So now we can go for our tea break. 15 minutes tea break. 15 minutes. Mariam, you can get the panel ready. We want to do it quickly so that after the LFAS panel will also come in, and then we will go into question and answer. So let's go for coffee break now. Coffee, coffee, coffee.
People will ask a question about the presentation. When are we having?
Yeah, that's what I'm saying. When we come back from break, we do 10 minutes questions, and then we go into panel session. What do you think?
and 3, and we leave it there, please. So if you have any other, we can have a bilateral chat. We need to get to know where the question is directed in. I want to believe all the presenters are here to be able to respond. So do we start with you? Please, over to you.
Thank you, Mr. Moderator. My question goes to Dr. Nabil. On your slide on disparity in global health research and the disconnect between the disease burden and the scientific population output, my question is, are the samples and field data collected in Africa? And is it that there is no established clear national bioethic and data sharing framework requiring equitable co-authorship? I'm just curious to know. Then my next question is on presentation with from Associate Professor Uche. The approach in your presentation,
Just a second, let me find out if Prof is in here, because he need to respond to that.
Okay, it's not, he's on this table.
Could somebody check on him so that he'll be able to respond to that? Because once we pass that, then maybe you can skip to the other one, then...
no, it's just two questions.
Okay, fine. So maybe once Prof come in, then you can come in. Now, one question to Nebiu. I counted 3 people. I think in the benefit of doubt, we can give you 4. Please, let's limit them to only 4 questions. Now, I don't know whether there is any other. Okay. I know I counted you that is related to Nebiu, so then he can respond to all of them. I counted you. Is any directed to Nebiu?
Yes, I think it's also directed to MA.
So that he can handle all of them.
And thanks for the presentation. I wasn't actually surprised when you talked about the 3% knowledge that Africa will contribute to global knowledge on health. It was quite worrying. And I was just wondering, even the 3% that you talked about, in terms of funding, do you have an idea who funds this 3%? I ask that because we may be having financial challenges in conducting research and contributing to knowledge. So if this 3%, what percentage can we say in terms of finances come from Africa? And how is African CDC positioning itself to financially resource our research institutions and country to contribute to global knowledge? Thank you.
Okay, fine. Thank you very much. Was it just one question? Any other directed to Nebiu so then he can handle all of them? Okay. If there is none, I think we allow you to respond to those 2. Then we go to the other questions. Over to you, Nebiu.
Thank you, colleagues, for the questions. The first one, in terms of disease burden in relation to the publications output, that's very skewed, and from my point of view, it's also unacceptable. So you have raised the equity issue, equity partnership, and so on, so on. So in that lens, it's very unacceptable, and it's not fair for Africans to give their data, their sample, and the publication or the benefits out of it are affiliated with other countries. So we need to be very strong in terms of ethics, in terms of this equitable partnership, and working together with, there are a lot of reasons behind, probably from our side as well, we may not dare to contribute during the write-up, or probably others are like running away, taking our data and everything, and then they are publishing outside. So we need to strengthen our ethical systems. There are other Other research findings, by the way, I came across to read a publication in JAMA which analyzed research outputs that were funded by NIH. And sadly, it reported 51% of those research articles have no African authors. 51% of articles that were conducted in Africa have no African authors, which is sad, and we need to change. Anyways, we need to change, and there are different frameworks that we are developing in Africa. CDC, the governance framework, Afrocentric research ethics framework, and so on. So those frameworks can support, and also we need to strengthen our journal ecosystems and so on. The second one is on funding. Funding is a big challenge, so I don't have a clear data on the number of or the percentage of funding that we are providing in Africa, but we can imagine, we can see funding is very, very, very limited in Africa for research. There is advocacy, and there are commitments that has been made by African leaders to provide 2% of the health sector budget for research, but never implemented in any African. We are dependent heavily on external grants and donations. So we need to change that ecosystem, and Africa CDC is trying to push in terms of advocacy. As you know, Africa CDC is not also a donor organization, and we have limited capacity in terms of financially supporting countries to implement research. So we are advocating for the ownership of the countries and domestically resource their research efforts. Thank you.
Thank you. Are you okay? Okay, fine. So maybe we take the other one, then we come to you as the last. Prof, I think then we'll revert back because you just, for the other question that he asked after the others. Okay.
Okay, my name is Wafa Said, and I'm here representing UNICEF. I'm also a citizen of this continent. So my question is addressed to the colleague who made the presentation on public finance management. And I wanted to ask, do we have also examples on having a compact between the ministries, for example, of health and finance? Because I think it's very clear that the ministries of health are aware, they're asking for the resources and so on. I think maybe just the colleague before, and the problem is that in implementation. And I wanted also to see whether there are examples or different narratives, not just only for health outcomes, that, for example, look at how, for example, member states in the Western region who invested more in health, what happened to the economy, to security, to stability, because I think maybe there is also need for a different narrative. So my question is that, what kind of compacts do we already have, for example, between ministries of health and finance to that regard? Yeah, thank you.
Okay, Gabriel, I hope you got the question. Okay, fine. Any other directed to him? Do you have, or is it separate?
No, I have question for at least one for every presenters.
Okay, maybe to him, then he answers that. Then, of course, the others.
Let me ask all my questions.
All of them. Fine.
So
Okay.
they pick it if it is them to answer.
Okay.
Ok. La première chose que je veux dire, c'est que par rapport à la première présentation, en réalité, on parle de la souveraineté sanitaire ou de la gouvernance sanitaire. Mais le problème, je me demande si ça ne vient pas de, par exemple, comme c'est Africa CDC là, est-ce que ça ne vient pas de vous-même? Et je voudrais savoir, par exemple, quel est le lien entre cette approche-là et celle relative à ce que nous appelons une approche pan-gouvernementale de la gestion de la cité, c'est-à-dire the whole of government approach. Parce que finalement, bon, par rapport à la question de ma précédente collègue là, c'est que il y a quelques semaines là, vous avez Africa CDC a réuni les ministères des Finances pour parler de comment financer. Mais en réalité, est-ce que le ministère des Finances a même la possibilité de décider en lui-même, sans le gouvernement entier? Or, est-ce que si on adoptait une approche pan-gouvernementale de gestion de la santé, ce n'est pas mieux, de mon point de vue? Donc, je voudrais que vous réfléchissiez à cela. Deuxième préoccupation, c'est que quand on voit l'ensemble des présentations, vous avez souvent au niveau institutionnel des idées. Je me demande si ce sont les gouvernants ou les chefs d'État qui viennent à mettre ces idées-là en place, ou bien vous leur suggérez ça. Parce que ce que vous dites au niveau institutionnel, ça n'a jamais d'effet au niveau pays. Au niveau national, les gens travaillent comme ils veulent, ils n'acceptent même pas des choses comme vous avez mentionné ici maintenant. Il y a beaucoup de choses qui sont venues d'en haut, en tout cas de Africa CDC, et plusieurs pays sont restés encore sans bouger, alors qu'ils faisaient partie de ceux qui avaient approuvé ça au niveau institutionnel et africain. Donc je pense que vous devez trouver des stratégies. Et quelles sont ces stratégies-là que vous avez pour que les choses que vous imaginez au niveau institutionnel soient traduites au niveau national? L'autre chose, un exemple, c'est qu'il y a beaucoup d'agreements que vous avez et vous proposez au pays. Mais à mon avis, y compris le dernier qui a présenté sur les CUSP, vous voyez, en réalité, est-ce qu'on ne va pas trouver la formule qui nous est propre en Afrique, qui est d'agir sur les déterminants sociaux de la santé? Parce que tout ce qu'on fait là, on dépense, mais on n'a pas de résultat. Et nous disons que nous n'avons pas de moyens et on veut chercher de l'argent au niveau local. Est-ce que agir sur les causes profondes ne va pas nous aider plutôt? Et que d'attendre que la maladie intervienne avant de commencer par courir et de dire où sont les centres d'opération, d'urgence, tout ça là, ça nous fait gaspiller de ressources sans résultat. L'exemple, c'est que on a en RDC maintenant un cas qui fait la honte de toute l'Afrique. Et je peux vous ajouter un exemple, parce qu'avec la CEAC, par le truchement de l'OMS, j'ai fait un document pour la région CEAC. Et ce qui s'est passé, c'est quoi? J'ai proposé qu'on aille au niveau communautaire pour améliorer les conditions de vie des gens. Les gens disent non, nous on a l'expérience de Ebola, on va traquer ça. Mais aujourd'hui, là, 17e est arrivé. Et ce n'est pas la fin. Si on continue de faire comme ça, la 18e va arriver et ainsi de suite. Donc il faut qu'on fasse attention. Moi, je voudrais attirer votre attention sur ces éléments-là. Merci beaucoup.
Okay. Thank you. I think, Gabriel, I don't know whether you got the first question and any that came to him. Then from there, maybe I would also give RD, perhaps to summarize some of the issues or questions that came from that. Particularly if there was any question to Wami. Okay. Gabriel, do you want to respond to that first one? And if there's any that came from that, then maybe I'll give the RD to.
Thank you so much. There is no specific question for WAMI. It's a reflection on the way we should address the health issue in Africa, specifically taking in consideration our own context. And I totally agree. For example, during COVID-19, when we talk about social distancing, and when you take some of the households, you have about 7 people sleeping in one room, and you are asking about social distancing. How do you apply that? So it's a lot of things that we may need to consider by developing some of the approach that can address our own context. I want to make a comment on 2 things. The data sharing agreement. You know, the data sharing agreement is very important for me because we started this process since 2021 when I was leading the surveillance division. And this is about 6 years actually, and we're still pushing for this. It's a process that all the member states already get their input. Those data that we are requesting for, they are just public health events. If you take EBS, it's all the public health events that occur at country level that we want to share. So it's an opportunity to advocate for this again. Let us try to join action to our speech for this data sharing agreement. In terms of health financing, when we take even WHO is talking about evidence-based resource allocation. We want this to be at member state level, and I'm already addressing the question from Prof. David. How do we develop our strategies, our frameworks, and why this is not applied at member state level? The challenge we have is Africa Union, the mandate is, if we take Africa CDC, our mandate is to develop all those evidence-based resources. But member states still autonomous. They can choose to adopt or not to adopt. If we take the Abuja Declaration, it's a declaration where all the member states say it's good for us. But how many member states have applied this? You see? So what we are doing is when we develop a framework, we try to work with member states to adopt it, and we work with member states to apply it by developing micro plan at country level. If we see the Lusaka agenda, we have staff at member state level. In West Africa, we have staff in Sierra Leone, in Liberia, to help, and we have one at the regional level to help member states to adopt, to apply, and to roll out. So that's the tricky one. We can tell, we can generate the evidence. We can have a policy brief that show the evidence that if we do this, it will help us. But member states can still say, okay, we agree, but we are not yet there. We will take our time, or we have other priority, and Africa Union, Africa CDC doesn't have that power to say you have to do it. No. They are autonomous. That's the challenge. But we keep pushing, we keep advocating, and we are expecting that we will get there. We are expecting that we will get there. If not, if you see, you talk about CUSP. CUSP is a EOC. We have evidence that if you have a great CUT, a great EOC, you respond fast. You meet the 717 target. But some countries still say, okay, the old way of managing outbreak is better for us. We're still pushing for that, you see? If we take the establishment of MPHI, there is an evidence that if you have an MPHI and you are coordinating, you have a way to maximize in terms of resources. You don't waste time and other things. You work as one team. But some member states say, for us, the old way is better because it helps us to address ABCD. So you see, but we cannot say, no, you have to. We will advocate, develop policy brief, and push for this. But the final say is for member states. That is the challenge. Thank you so much.
Thank you, Ardi. Gabriel, I hope you are covered on that. So I think with those questions, oh, you want to add something, Gabriel? Yeah. Okay, fine. Okay.
Thank you very much. Ardi has covered 60%. I want to also respond specifically to the request on the availability of compact for Africa, for example. You know, really, initially before the new SDG, you have IHP country compacts, but when the 2030 universal health coverage SDG agenda came in, so the thinking was around universal health coverage. How do we bring people around the table with the aim of achieving universal health coverage? And World Bank have instituted few compacts. For example, in 2025, there are some countries that have, compact. Countries like Nigeria, Sierra Leone. We have Uganda. In Africa. So you have a couple of countries that have actually, signed compact, with the support of the World Bank. But what is more interesting to say is, whatever we do, partners, donors do, the key principle is country ownership. Even without the compact, the countries can implement one plan, one budget, and one reporting. So it's all rely on the leadership of the ministry to say, look, we are going out of silo planning to one unified planning. You may not have one, for example, one strategy plan to be able to cover the entire health sector, but you can develop an annual operational plan that brings every donor on the table. And that's very possible. We have tried it in other countries, although it's challenging, but what we are advocating is transparency and accountability. Resistance is within normally, and donors are very open to that combined operational planning, where you bring all the donors' plan. For example, 2027 implementation, you draw your 2027 implementation and bring all the donor funding into that implementation plan. That shows how much holistically you plan to implement in 2027 and what you intend to achieve. The resistance is not from donors, but it's from within the country specifically. So that's the challenge. But we will support countries to overcome those challenges. Thank you.
Thank you, Gabriel. I believe you got the feedback. Okay. Before we move to the next, we had one question for Prof. I think you are away, so I don't know whether you want to repeat it. And after that, we end these sessions. We go to the next.
Thank you very much, Mr. Moderator. My question was to Prof. Uche. In your presentation of the AMR section, you made mention of weak multisectorial coordination, 27%. My question is, which ministries were involved? Because you cannot talk of AMR and leave the animal and environmental sector out of it. So I want to know, how did you arrive at this 27%? Thank you.
Thank you very much. That's a very good question. So those findings come from the first phase of the project, which is the environmental scan and literature mapping. So this is essentially information that is available in the public domain. Now, because we have 3 phases of the project, the second phase, the virtual consultation, allows us to interact with focal points across the member states to, 1, validate the data that the literature is telling us about, but then 2, to get more insights about some of the things that are happening on the ground that is not captured or effectively disseminated through the data. So that figure and the percentage that I have shared with you all are things that we have extracted from information that is available in the public domain. And it is showing that there's very weak multisectoral coordination process taking place. Yes, all the 15, yes, we mapped all the sectors that has implication for AMR. at least to the extent that it is available in the public domain. Yes.
Thank you very much. I think that marks not the end because I'm skipping one presentation from Dr. Modu. He will come in later. But for now, allow me to jump to the next session, which will be facilitated by Dr. Elfas and Dr. Miriam to provide guidance on that. Dr. Elfas.
Sorry. Good afternoon. Is it afternoon? I can see people are so focused on their laptops. And I would request us to just stand. Let's just stand. Let us just all stand, please. Let's all stand and just stretch, please, just stretch. As far as you can go, stretch. Okay? Down. I know most of us went for what we used to call PE, physical education. And we'll breathe in and then say out. Okay? So you want to breathe in. When you breathe in, just go up. Breathe in, out. Again, in, out. Okay? So let's have seats. Thank you so much, my dear participants. We've been listening to presentations right from the morning. And we have a session. But we also want to bring the best, some of the best panelists that we have in this forum, to be able to draw a lot of experience from them, and also to be able to get a lot of learning from them. My name is Elfas Ojiambo. I am the Partnership Officer for the West Africa region at Africa CDC, and I'm from a beautiful country called Kenya. I speak Japanese, I speak Chinese, I speak French, I speak Kiswahili, but I like speaking English. Thank you so much. So, I would like to request some few of our participants to join us up here as the panelists. And I know that we listened to some presentations around Africa health, security, and sovereignty. We listened to a presentation around the Lusaka agenda. We've listened to a presentation around the knowledge hub. And we've listened to a presentation on AMR. All these put together gives us an opportunity to be able to build a very strong background in terms of our understanding on things happening. And therefore, what are the various perspectives? How can we as Africa CDC respond together with our member states in a much better and a much coherent way? So, in this particular session, I would like to invite our dear colleagues, Madam Fatma Zana. Fatma Zana joins us from the GIZ, the Regional Pandemic Preparedness Prevention Project. I call it Regional PPPPPP Project. So please, let's all appreciate Madam Fatma. There was a lady who joined us from UNICEF, and she asked so many difficult questions. And she is the country representative for UNICEF in Nigeria. So our dear Dr. Wafa Said. One thing quite interesting with Dr. Wafa is that she was a country representative for UNICEF in Somalia. How many of us here have been to Somalia? How many? So only the 4 of us. Thank you. So we have an expert here from Somalia with an in-depth understanding of humanitarian and development matter. We also have our colleague from UNFPA, Dr. Azi. Where are you, Dr. Azi? Azi's other name is Kofi. And for us who come from the West Africa, the only Kofi we know is Kofi Olomide. The Lingala musician, right? But in West Africa here, Kofi is a very, very prominent name. We also have our representative from WHO. Dr. Ohene is representing the representative for WHO in Ghana. And I had a very interesting conversation with Dr. Ohene because she called me and asked, where exactly is the meeting happening? And I said, yeah, I'll share the information with you. But she's been so much committed to join us in this particular meeting today. Finally, Africa CDC has a partner that we call each other brother, sister, and that partner is based in Abuja. It's called the Regional Center for Resilience and Disease Control. So, Madam Imabong, please join the panel. So, dear colleagues, we'll go through, we only have about 1 hour to go through this, but I believe that it can be a very intense 1 hour of conversation. We are quite okay. We are quite okay with the panel as it is, dear participants. No. Please, please. So this is the panel that we have. It happened that we are inviting organizations, right? And these are the people representing those organizations. So there's no way we would have told WHO that please send a male representative. And there's no way we would have told GIZ that please send a male representative because we have another female representative from WHO. And I don't think even whether what they're going to share will consider those things of whether I'm a male or female or whatever. They're going to share knowledge with us, right? So I have a question to the panelists. Thank you so much for accepting the opportunity to join us. And I will start with our representative from UNICEF. Can you please share with us how your organization's mandate supports the objectives that were shared in African health, security and sovereignty and the Lusaka agenda?
Okay, thank you so much, So, for my organization, UNICEF, our mandate, of course, is to support member states at all levels. And I would like to share 3 points. So, for example, we've been talking here about an aspiration for Africa health, security, and sovereignty. And I think what matters is that how do we work with member states so that that aspiration turns into services that the communities experience every single day. So that's the first point. And I'll maybe give one example in an area where we as UNICEF, as part of Gavi Alliance, including my WHO colleagues sitting here, which is, for example, immunization. And if we look now, if we want to reach the children who are not vaccinated, or we call zero dose, so it's a problem-solving exercise where you have to look at data. Yeah, the other one. Okay, let me try to speak closer to him. Thank you so much, Fatima. We have to look at data. We have to look at. I think this one is not. Okay, now let me try to use this one. Thank you so much, Prof. So we have to look at data, we have to look at surveillance, we have to look at supply system. We spoke a lot about community trust. So these are the same ingredients that if we have to have health security, we also have to work on this. And so, for example, for us, as an entry point, for example, to support in immunization, it's not just about the service, but how do we strengthen the systems, the national systems across these areas to support the health security agenda. Another point that is very important and has come in many of the presentations yesterday and today is this whole issue around procurement, local manufacturing. As UNICEF, for example, we support procurement in more than 100 country member states. And I think now we realize, for example, the vision of Africa to have by 2040, I think maybe 60% of the vaccines to be produced in the continent. And so we're already using our expertise in this area to support the member state in having local manufacturing and working on that. So that's one area we are also supporting based on our mandate. And I think the last also point that I want to flag is the issue of equity. We are talking about sovereignty, and sovereignty has to work for everybody. So for example, it doesn't make sense if we have the vaccines in the national warehouse, but the child that is most at risk or at the furthest community are not getting it. And I think this issue about focusing intentionally on communities that are most likely to be left behind, people living in displaced communities, people living in, migratory routes. So this is something very, very critical in our engagement. Is this also equity focus on the population that are most at risk? Thank you.
Thank you so much, Madam Wafa. But I want to bring the same question to WHO, and just building onto the conversation that has come from UNICEF. How does this fit within your mandate? How do you help to actualize this mandate?
Thank you very much. Good afternoon, distinguished ladies and gentlemen. So thank you for the question. So WHO, our mandate is to promote health, keep the world safe, and to serve vulnerable populations. So if we take, for example, keeping the world safe, which has to do with health security, one of the things that WHO does is to support our member states to strengthen their international health regulation capacities. That's their ability to prevent, detect, and respond to public health threats. So to be able to do that, we support what we call the joint external evaluations, where we do an objective assessment of the IHR capabilities. And after that, we also support the National Action Plan for Health Security. So that is based on evidence from the IHR joint external evaluation, because that exercise identifies priority gaps so that when countries are planning, they can use that evidence to identify the priorities to support. Another area that we also support in terms of the AHSS and the SAC agenda is to promote regional collaboration and governance. So we take advantage of our regional and country offices in all countries, and we facilitate learning and information sharing between countries, knowledge exchange. So for example, recently, a team from Ethiopia was in Ghana to learn about our health insurance system. And we've done that with other areas that countries can learn from each other. So in that way, we realize that then countries share their best practices and strengthen their systems internally. That helps to improve sovereignty. And then the third area is we support evidence-based decision-making, and these are done through surveys. We also generate norms and standards that countries can adapt. So, for example, one of the areas we support is a health workforce labor analysis, where we look at the gaps in terms of health workforce and the needs to be able to strengthen primary health care towards universal health coverage. So in promoting these areas, we promote health sovereignty, also health security, that helps countries stand on their own to improve the health outcomes of their populations. Thank you.
Thank you so much. And just building onto that conversation, I would like to hear from GIZ, Madam Fatima, in terms of how does your mandate resonate with the presentation that was made around the Lusaka agenda objectives and African health security and sovereignty.
Thank you very much, Dr. Alphas, and good afternoon, everyone. So for GIZ, GIZ has been a long-term partner of Africa and African countries, and has established structures that mimic the setup of the different instruments that we have on the continent. GIZ's entire vision revolves around building a world worth living. So we have a long-term vision towards ensuring that all the sectoral areas that we engage with are leading to regional stabilization, economic integration, so that at the end of the day there's prosperity for the continent and beyond. Health is treated as an important cross-cutting topic for all GIZ interventions, and in our health architecture we reflect national programs that work closely with national partners in implementing strategies and initiatives that are relevant to the context of the country. But we also have regional setups that work broadly on the topics of health security, recognizing its importance and also impact when it comes to other topics like trade and migration. We also have global interventions that seek to develop, generate knowledge through research and development, but also piloting new interventions and innovations that can be transferable across continents and borders in the countries. When it comes to our partnership on the African continent, GIZ, through the German Ministry for Economic Cooperation and Development, has a partnership agreement that spells out our relationship and cooperation with the African Union and Africa CDC, to be more specific, when it comes to the topic of health. Part of this reflects very clearly the mandates and the throngs of the Lusaka agenda, ensuring our interventions are country-led and country-owned, ensuring sustainability is built into all our interventions, that transition planning is a primary objective. As an example, we have the Strengthening Africa Health Architecture Program, which works very closely with Africa CDC, which is based in, also based in Addis, and working closely with the Secretariat. And over a number of years, they have invested primarily in supporting building the organizational capacity of Africa CDC, right from the times of COVID all the way to Africa CDC's current journey to the HSS. So in a nutshell, we reflect those interventions then and transfer it to the country and regional levels. In the West Africa region, we have the regional support to the ECOWAS on pandemic prevention and response, working with all the member states of the ECOWAS and supporting on cross-border initiatives. We've supported topics around surveillance and the establishment of the regional surveillance mechanism, EcoAlert. I'm sure Imaubon can speak more to that. But we're increasingly also looking towards sovereignty when it comes to access to local locally manufactured drugs, healthcare industrialization, so that health is increasingly being treated as an economic topic that requires border integration rather than being treated in isolation as a welfareist topic that requires heavy investments. This also seeks to strengthen the argument when it comes to approaching our governments and requesting for or advocating for additional resources. Domestic resource mobilization is a key part and a key throng of the WARCC agenda. And what we have seen over time, we have the Abuja Declaration of 15%. There are only like 3-4 countries that have met it on the continent. And when you probe into that, it is largely the argument is weak because health is seen as this sector that absorbs a lot of funding, and in the end, we hardly have data strong enough to strengthen the argument for further investments in health. So how do we change the narrative around investments in health to show that health is the impact of health translates across all other sectors of the economy, and it is a sector worth investing in? Thank you.
Okay, thank you so much. Quite a lot in terms of alignment of your mandate when we come to the WARCC agenda and the AHSS. But this is not smooth sailing. There are challenges that are faced in between. And I know if I go to UNFPA, for example, can you kindly share with us some of the challenges that you see or that you envision to experience in the implementation of this process?
Yeah, thank you very much. I'm glad I'm here. I'm the only man on this panel. Fortunately, my organization, UNFPA, deals almost exclusively with women and young people. So I'm still representing women here. So for us at UNFPA, our priority is that we want to ensure that every pregnancy is wanted, every childbirth is safe, and every young person is able to achieve their full potential. In carrying out our mandate, there are a lot of challenges which I want to talk about under 5 main areas. The first area is the persistent weaknesses in our health systems and inequities that exist therein. For instance, there are gaps in our accountability mechanisms, surveillance systems, specifically relating to issues of maternal health, where we lack one critical component of maternal and perinatal death surveillance and response, especially at the community level. The issue is, are we capturing the community level deaths, even in our maternal mortality figures that we record every year? Last month, there was an AU Health Summit, and one of the key areas that was focused on were strategies to reduce maternal mortality in Africa. And for us, one critical area we need to look at is whether we are actually even counting the right numbers. So our numbers may actually be higher than what we are recording. Other areas, other weaknesses in the health system relates to the workforce. For instance, in Ghana, we are facing challenges with brain drain, where most of our health workers are moving overseas for greener pastures. Critical health staff, especially midwives, who can provide up to 90% of sexual reproductive health services, are leaving the country, leaving significant gaps. There are issues of distribution of health workforce, where the health workforce is concentrated in the urban areas and less sparsely distributed when you go further away from the major centers. The other issue I want to touch on is heavy reliance on external support. We've mentioned time and again here that there's a need for looking for mechanisms that will sustain our finances so that we can fund our own solutions. Then dependence on external supplies. For instance, we know that for reproductive health commodities, the production is quite low in Africa. We still rely on imports from external sources, and there are even challenges within that area. For instance, in Ghana, a change in the consignee agreement has led to significant delays in clearing contraceptive commodities from our ports, some delaying as long as up to 6 months at the port. So there are critical challenges with even local manufacturing of our commodities. The next area I want to talk about is fragmentation of across sectors. So a lot of interventions are put in, donors come with a lot of interventions, but these are not well coordinated, and therefore we have a lot of duplication and redundancy, and we are not really getting value for money. Then lastly, I want to talk about conflicts, humanitarian crisis, climate shocks, and displacements, which can potentially disrupt normal services, health services to societies. So these are some of the challenges that we are encountering in our work. Thank you.
Thank you so much, Dr. Azi. But I also know that Imabong, that working for the Regional Center for Disease Control, the ECOWAS Regional Center for Disease Control, that you're also experiencing some challenges in terms of implementing this particular agenda in the West Africa region. Would you kindly share some of those challenges?
Okay, thank you very much for your question. Before I start, I would like to touch on the issue of health sovereignty, and I'll state that it doesn't necessarily mean, for us, it doesn't necessarily mean that the regional African countries or the regional institution will have to work in isolation. It doesn't necessarily mean that they'll have to have their own technologies or medicines, but it also means that they can set their health priorities, they can finance them, they can retain workforce, because of the brain drain, and have access to health commodities when needed. And I'll also like to state that a country might have a very strong lab capacity or emergency preparedness capacity, but if it does not, talk to another country, if it does not report, then there is a threat. So for us at ECOWAS, RCSDC, regional cooperation is a very strong health sovereignty factor. So now back to your questions, the challenges that we face. The first will have to be financing and sustainability. Most of these surveillance and preparedness programs, they are dependent on donors. And the moment we move from that donor-funded project to predictable African financing, that health sovereignty will not be achieved. So that is the first one. And the second one is the fragmented surveillance and weak interoperability. Even countries that use TIH2, they have issues with, fitting in very well, because at the point where you'd have to report for animal, from the animal sector and the environment sector, it's always a problem. But WAHU, through RCSDC, there are plans in place for the EcoAlert, and we've gone very far on that. And the good thing with EcoAlert is that it will receive data from the animal, environment, and human sector. And what data they're receiving? They're receiving data on lab response and surveillance data. So that will solve for that fragmented and weak interoperability. And the other challenges is shortages and uneven distribution of skilled workers. Technology alone will not do the work because of the brain drain. you train people and they leave public institutions and then migrate. So that is a major issue. The other one is the weak regional coordination and implementation. Countries are not speaking to each other, and you know that can be a threat. So when it happens like that, we do not have data to work with. And you know, a threat somewhere is a threat everywhere. So I'll stop there for the challenges. Thank you.
Thank you so much, Ima. And I just want to build on to your last point in terms of the weak collaboration and coordination. And we know very well that sometimes when you have an outbreak, the outbreak does not know whether you are coordinating or collaborating. An outbreak is an outbreak. So how best then do we respond to that? And I would like to listen to possibly get a response from WHO. How do we enhance this regional collaboration and coordination?
Okay, thank you very much for that question. Yes, enhancing regional collaboration is very important. As you rightly said, outbreaks don't know borders. So it's really important that we work together. And as partners, we have to go beyond the parallel support and synergize our efforts to support countries. So it's important that we align our collective support behind national plans, national priorities. So I think recently WHO and Africa CDC, they came together for the Continental Ebola Preparedness and Response Plan. That was a very good initiative, because with that, then we stop the duplication and we see how we can harness each other's comparative advantage to support the countries and also neighboring countries in their efforts. I think another area is also to improve information and intelligence sharing. It doesn't help countries when, for example, WHO develops a CTREP, Africa CDC develops a CTREP. We need to share information and harnessing the country data to support the data sharing and also surveillance. So if we have regional protocols, that's also guide partners in how we can collaborate in supporting countries. That's also very good. And then another way is harmonizing technical and operational support. We provide, different partners may provide technical assistance, but how do we avoid duplication? So it's important that we rally around common standards and guidelines as we support our countries. And then supporting public health assets. So for example, I can use Ghana's field epidemiological training program as a good example. And in that program, we have residents coming from several West African countries, and they are supported by several partners, COICA, US CDC, WHO, Africa CDC. So that is what we should be doing, coming together to strengthen our institutions for public health workforce, for laboratory, and then also for surveillance. And I believe in the discussion, the issue about cross-border collaboration is also important, how we can bring the countries together to share information and strengthen institutions. And then finally, sustainable financing. We need to strengthen domestic resource mobilization. Yes, partners may provide some catalytic external funding, but it's important to promote health sovereignty, that countries really look domestically to see how they can mobilize resources to support the health security agenda as well as the health system strengthening. Thank you.
Thank you so much, Dr. Ohene. Your emphasis on synergizing, aligning to national plans, information and intelligence gathering and sharing that information, and avoiding situations where we don't strengthen our health assets, public health assets, and knowing very well that diseases do not need passports to cross. But I just want Fatma to add on to that. From GIZ's point of view, how can we strengthen this regional collaboration?
I think I'll pick up just where the WHO colleague left off. When we say health has no, recognizes no borders, I think as a continent we also need to work with the mindset that our expertise should not have any borders. If Nigeria has access to experts, there's absolutely no reason why other countries on the continent should not be able to leverage the expertise of Nigeria. And I'm just using Nigeria because I'm partial. Yeah, so whether it's in the deployment of rapid response teams, but also just intellectual capacity, all right? Ideas should be transferable. Our communities, though different, are quite homogeneous in the way we function. And that is an area of strength that we can leverage as a region. Our organization does not necessarily need to reflect external forces or market forces, but we can leverage more on the socio-cultural norms that we have as strengths to be able to promote community-led interventions, community-owned interventions that are less to do with financial resources, but rely more heavily on human resources. I think another approach we need to internalize is changing the mindset that what we have is not enough, right? Being stuck on the numbers. There's a stronger argument to be made in showing what we can do with the little we have that will attract those that are willing to invest in what we believe in, rather than constantly arguing that we have not reached a certain percentage and therefore we do not have enough to deliver on the mandates and the responsibilities that we have towards the population on the continent. Most of the African continent is employed in the informal sector. That's the informal private sector. So how do we engage more with those sectors to leverage their resources, whether financial or whether human, in order to strengthen the formal health sector? There's a good example in Nigeria. For example, we have the Health Fellows program. And this is a program that recruits young persons in communities, one person per local government area, and they can be from any walk of life. And they apply, they get a basic training for about 2 weeks, and then they go out into their communities and implement passion projects, right? Some of them do complex projects like reaching out to private sector investors that then support them with revitalizing primary healthcare facilities, but some are as simple as going around and reminding community members you can access social health insurance. There is a private healthcare facility over here. If a pregnant woman is in labor at this hour of the day, you can call this person to take her to the hospital. So really simple things that have tangible effect when it comes to the person that matters the most. So for me, I think as a region, we need to start thinking of the unorthodox methodologies that we haven't leveraged in the past, to look at how that helps us to transition and bridge this gap now that has focused so much on financial resources, but maybe the answer is not stuck on the numbers. Thanks.
Thank you so much for that kind of response, basically saying that we need also to change our mindsets, you know. We need to leverage on the expertise that exists within the region so that then we use it effectively to address issues concerning the AHSS and also the ReTAC agenda. But we exist in an era where there's a lot of innovation happening. Some of us who have young Gen Zs, you know exactly that if you are having a phone, for us the only thing we use the phone for is for calling and texting. But you get a phone to a Gen Z and they'll do some wonderful things. They are quite more used to the technology and the innovation that is happening. So, Dr. Aziz, how do we harness What are some of the technological advances or some of the innovations that you can use to be able to enhance this regional collaboration in the West Africa region?
Hello? Okay. Thank you very much for that question. So, in terms of technology and innovations, I think that there's a lot we can leverage on, specifically to strengthen our health systems and make and improve our health security. So we can look at digital health and data-driven systems. There are a lot of examples that I want to share with you. For instance, in Sierra Leone, they implemented what is called a press track software, which is able to register pregnant women and track them and then flag when there are high-risk situations that require interventions. And we know that Sierra Leone has come a long way, started with a mortality of around 1,600 in 2000, in the year 2000, and that has reduced to about 400 in 2020. So over 20 years, they have significantly dropped their maternal mortality, and they are aiming to do that further with some of these innovations. Here in Ghana, UNFPA has supported the development of a timer alert system, which really is a game changer, because when it comes to maternal deaths, we talk about the 3 delay system, where there's an initial delay in taking decision to seek help, and then there's a second delay in reaching the facility. And this timer system addresses comprehensively that second delay. What the application does is that it connects the pregnant woman who needs emergency care with a transport provider and then also to a healthcare provider at the same time, either using an online platform or an offline USSD platform. And then the whole structure is supported by a mobile money platform where communities can leverage on a crowdfunding platform. Everybody puts in a bit of money so that when the pregnant woman clicks that button, she doesn't need to have money at that material moment. Immediately she's linked to a transport provider who transports her, and that transport provider is paid through that same system, and the healthcare provider is alerted that there's an emergency coming, and then also connects them to a blood system. So this system has been developed and has been piloted in one of our districts, and we are looking at scaling that intervention up and possibly sharing with other people who may be interested in some of those applications. The other one I'll briefly talk about is a national digital blood system, which really gives you a dashboard where you can in real time know which facilities have blood products available, because often in Ghana, and I'm sure it pertains in other countries as well, the problem is when you need blood, you don't know where to find it, and you have to run around. What this does is that it tells you that there's blood at this specific location, and then you can request for it using that same platform. The other area we can talk about is using technology to overcome distance. So leveraging on things like telemedicine, drone technology, which was also implemented here in Ghana, delivering life-saving interventions to hard-to-reach areas. Then we can talk about portable diagnostic technologies that can really improve access to health products. Then we can also talk about innovations within our supply chain system, where we can talk about regional stockpiles, and then pooled procurement. So maybe 3 or 4 countries can come together and decide that let's keep our central warehouse in this country, a strategic location that may be at a good distance from all the participating countries. And then what it does is that then they pool their procurements together, and by doing that, they can leverage on economies of scale and get more competitive pricing. The other thing that does is that anytime there's a humanitarian situation where there's a stock out, rather than trying to import and going through the lengthy process, then you can fall on that a warehouse to then limit the waiting times and other things. So there are lots of ways in which we can leverage technology. Thank you.
Thank you so much. Imabong, what kind of innovations and technologies can we utilize to enhance collaboration in the and implementation of this HSS agenda?
Okay. Thank you very much for your question. So the very first innovation that we can adopt is local manufacturing, because health security is not just responding to outbreaks, but being able to have access to health products or whatever it is that we might need when the global supplies are depleted. Because COVID showed this, our PPEs were not in place, everything had to be imported. So that would be the first. Community-based surveillance, that can also be adopted because diseases start in the community and sometimes they end in the community. So because of the issue of One Health now, those in the communities can be linked to those in the veterinary sector or services, public health, and also the animal health, so that they'll be able to spot these things when they arise. Cross-border collaboration, countries cannot work in isolation, they need to talk to others. We are actively doing this in ECOWAS. So this will have to be cross-border surveillance, joint emergency and preparedness responses. The next one will have to be strong African health security workforce. As I said earlier, that technology cannot do all of this. We need people on the ground because of the brain drain. They can be trained and hopefully retained. The other one will have to be cross-border rapid response team. This is a project I particularly worked on. We have a database of 700 personnel that is multidisciplinary across the 12 member states. So these people are waiting to be inducted in about 2 months from now. So those are the approaches that can either be used or adopted. Some of them we are actively implementing them at the center. Thank you.
Thank you so much, Dr. Wafa. From that list of so many other innovations, what can you be able to add? I think it's a long list.
Okay, thank you so much. I think my colleagues raised a number of points. And I also want us to think that innovation, of course, now we have technology and AI, but also innovation can be institutional. Innovation can be a practice or an approach where institutions do things differently. It can be simple, but can also have a transformative impact. And I think one of the things that we can look at is, for example, how we can have an integrated community health workforce. I think we often find at the implementation level, you find health workers first out of the system, linked to a disease, linked to a program, linked to nutrition or immunization. But I think also having integrated community health workforce that works across the communities, linked to the community and not to a disease, that's also a simple way of doing things differently that has impact not only on the quality, but also has impact on effectiveness and efficiency. And I think, like my colleague from ECOWAS mentioned, that we also have to look at how we can have real-time surveillance by engaging the community, how AI and technology can help us to bring that. And this is something we need today and now. I think we're all in the continent, no matter in which corner. I'm thinking now about Ebola and how in many places our system is weak. And also that, for example, it was the early detection, prevention. So I think we have to think, how do we bring the community? I have to say, I served in the front line in many places. I have seen real suffering. I think it was the professor yesterday who was saying, when we see these numbers and event, we have to remember that these are our people. But I also seen at community level wisdom, agency, capacity. So how would you bring that in through that? I think also my colleague from UNFPA spoke a lot about AI and technology. And one thing that we have to think about, because we're talking about sovereignty, as we bring that in, what does that mean in terms of the governance of the data? Who owns the data? How can we have data protection? How can we also ensure protection of the information of the people? As we bring AI and technology, that is something very, very important for our continent. Thank you.
Quite an interesting, and as we move towards the tail end of this conversation, maybe we'll just do the last round, listen to Imabong. We'll start from this end going the other side. Looking ahead, what strategic priorities should guide partnerships to ensure the realization of the AHSS agenda?
Okay, for us, it will have to be regional. For us, it will have to be regional collaboration. Partnership should support regional and continental collaboration, and in terms of cross-border surveillance, information sharing, and joint preparedness exercises. The second will have to be sustainable financing models. We cannot keep depending on emergency donor funding. So partnership can be on co-financing and domestic resource mobilization. And of course, local and regional manufacturing. As I said earlier, that COVID had, exposed this. So there can be sort of technology transfer, because when that happens also, there'll also be, the workforce will also be built, because people will have something meaningful to do when these things are provided locally. Thank you.
Thank you so much, Madam.
Okay,
Dr. Ohene.
Yes, thank you very much. So looking ahead, it's also important for us to remember that governments actually hold the ultimate responsibilities for their people. So it's really important that we have strong political leadership and commitment, and for partners to align behind country-led health system strengthening and health security systems. So we need to rally around the national action plans, the health term medium plans, the national priorities, so that we support sustainable progress. The other thing is also to remember that health systems strengthening also goes with health security. They are not mutually exclusive. As we invest in primary health care, immunization, health workforce, and so on, we are also strengthening emergency preparedness and response. So the two should go together. And then I'll also say that governance and accountability is very important. We should hold ourselves accountable. So that is strengthening public health institutions, evidence-based decision-making and planning, as well as transparent monitoring and evaluation systems. I would also say that we should embrace One Health. As we know, health is not just about human health. We have animal health. We have to include the environment, wildlife, water, and sanitation. So we need to ensure that we work together for the common good of the human, the animal, and the environment, even as we promote our health systems and also health security. Thank you.
Thank you. Madam Fatma.
Not much more to add on what has already been said. I think country ownership is important and key. As partners, we bring technical expertise, but really external development assistance is a gap filler, which means a framework must exist for anyone to come in and contribute to it meaningfully. Otherwise, we end up having all these parallel programs as they seek to establish short-term interventions with very limited long-term impact. Mutual accountability is also important. There must be transparency in investments, resource mapping and expenditure tracking that shows what all sources of funding or how all sources of funding are being channeled is important. It's not knowledge that should be unique or belong to a small set of individuals or partners. Multi-sectoral interventions, like you said, One Health is key. We've all increasingly seen the impact of climate on health, but also looking to health and education, or health and trade, health and migration. There are all these cross-sectoral interventions that we can leverage. Local manufacturing is really essential. We have the capacities, we have the workforce. How do we invest more in research and development in order to ensure we're developing medical technologies, leveraging APIs that are generated on the continent, and reduce the burden on our supply chain when it comes to logistics. And lastly, we talked about leveraging artificial intelligence. So how do we use the data that we now generate to build predictive models that tell us what is more likely to happen, so we can plan proactively rather than constantly reacting to disease outbreaks and epidemics. Thank you.
Thank you so much. I have to say I was very inspired by the Honorable Minister of Health of Ghana yesterday. And one of the things that he flagged is that about primary health care. So if you want to have health security, investment in primary health care is the most effective pathway. We know that because primary health care also, if you look at it, as I mentioned earlier, it's about the data, it's about the supply chain, it's about the health workforce, it's about the community trust and engagement. So you have all the elements that are, if they are working and resilient and strong, whenever you have an epidemic, and we know it's just a matter of time. This is our world, you know? It was COVID, now we have Ebola coming back, and so on. So our systems need to be resilient, and investment in primary health care is the basics for that. So I think this is, for me, one thing. How do we all, for example, whether in Africa CDC, whether the partners, to really make investment in primary health care is the most effective pathway for health security. I think we also spoke a lot about financing and domestic financing, and we have all seen how ODA have reduced, and it will not go back. Sometimes people think, oh, you know, is it a period? No, it will not go back. So we really have to think of the future where we don't have aid. And I think we all say domestic financing, but we also have to move more than that. We have to understand what challenges governments are facing not to be able to put the money on health. Many African countries are struggling with debt. Many African countries are spending more in debt management than in health and education. How do we, as, for example, whether institutions or us as development partners, support member states to have a fiscal space where then you can have space to invest in health? It's not that people are sitting and they just don't want to spend on their population. So we really have to think about innovative financing. We have to look also, I think sometimes member states say, if we want to borrow, why do we have to pay 3 times what do you call, the credit risk rating? You know, even African members said, I think, talking about having an Africa agency for credit rating, because it is politicized. It's not really directly linked, for example, to the concern. So I would like us maybe also to think, not just to ask for domestic financing, and I think we all say that we have to have a transitional responsible pathway to transit into domestic financing, because it cannot just be immediately a switch for many of the needs. But we also have to think about how do we create fiscal space. And I think now we have these terms of health finance specialists. I don't know if we have them in African CDC, that they bridge that and try to work on that area. I think this is something very critical for domestic financing. And the Honorable Minister was also saying, you know, we cannot have sovereignty if your core health functions for your population depend heavily on external actors. I think the last point also the Honorable Minister spoke about, and my colleague spoke about manufacturing. And I think for me the aspiration is not just for Africa to produce for itself, but to be also competitive in the global market. So we really have to think this way. One thing that I also take away, we've been talking about, for example, quality control, regulatory system, predictable demand, local procurement, I think it was raised earlier, but also I take one moment from the colleague who presented about knowledge management and research. So that also becomes important. If we have to produce more, we have to invest more in research. And for me, that was like a aha moment, because we were saying this, but that investment in research is very critical. So I would say primary healthcare, solutions for domestic financing, and also moving this issue so that the African member states don't rely heavily. I think it was 95%. You see, Elfas, I've been listening carefully and looking at the slide. I think it was more than 95% or something, medicine and vaccine, and that cannot be. Thank you.
Yeah, so thank you very much. I agree very much with a lot of things that have been said. Maybe just to highlight two issues. I think financing has stood out of in the conversation, because it looks like we need money to do almost everything that we intend to do. So maybe I'll just highlight some of the interventions that can be used. For instance, we have a UNFPA supply compact with governments where they progressively increase their investments in reproductive health commodities procurement, and then with incremental percentages, then they unlock some matched funds that can then be used for other things. So it's more like an incentive package for governments. That is a model that we can look at. Also looking at how do we get private sector to help us with our financing. And that feeds very much into data, because we need data for advocacy, and has been presented today. You can see that we are not investing enough in generating data. And this is a kind of data we need to advocate for financing, for instance. The other issue I want to highlight, I think one of the panelists mentioned political commitment. And this is very crucial. And maybe just to highlight with one example, where we are running this program called the Presidential Initiative on Maternal Health Emergency Response. And this is based on 5 strategic pillars. One is on mobilizing high political leadership. The second one is on accountability. The third on sustainable financing. The fourth is the clinical arm, which is being led by the deputy minister who left here just a while ago. And the last one is intentional intersectoral collaboration, which really recognizes that the health challenges are not only for the health sector. We need to look at how do we get other sectors involved in decision making. Because like we mentioned, we need Ministry of Finance, we need the transport sector. All those sectors are important if we have to make headway. So maybe just not to belabor the points, I'll end there. Thank you very much.
Thank you so much. Let's appreciate the panelists. And I just want to pick on to the last point, and it reminds me of the conversation I had yesterday with the general manager of this hotel. And I was telling him that this meeting is quite important even for him, because health is not just for those people who are trained in medical field. Even you as a general manager, when every now and then your staff falls sick, it's an issue of concern for you, to you. And therefore, you should also be interested in terms of participating in matters health, right? So we really appreciate the conversation that has been going up here. And I know I'm standing between you. Yeah, I'm just being warned. I'm just standing between you and lunch now. But just to, is there somebody with a burning question? Maybe just one or two? Madam Bongos? That's one. Another opportunity. Okay. Roland. So let's start with Ms. Bongos there, and then Roland, and then we finish it.
Right, thank you, Alphas. Thank you very much to the panelists. I just have a question for the gentleman from UNFPA. You know, you were talking about, you know, some of the digital pilots that have been, you know, rolled out. So my question is, you know, what kind of barriers to adoption are you facing in, you know, getting these innovations to the last mile, for instance, and how are you leveraging local intermediaries, maybe like Association of Midwives, Association of Local Traditional Leaders? You know, how are you leveraging these local intermediaries to encourage adoption? You know, and I think that also ties into the conversation around PAT investments, strengthening the PAT investments, and really just thinking this through towards achieving local ownership and sustainability. So even though these are innovations that are brought in, but how are we leveraging these intermediaries to encourage local ownership and adoption? Thanks.
Roland?
Yeah. Thank you so much, panelists, for the discussions. I think I really enjoyed it a lot, and I wish we could continue, just that time will not allow us. My question will go to ECOWAS. You did mention that you are doing a lot as far as the cross-border surveillance is concerned. We are very much aware some 3 countries are no longer part of ECOWAS. I just want to know what we are also doing across those countries, because when there is emergency, the emergency will not respect that these countries are no longer part and these countries are part. Yeah, diseases know no borders. So I just want to find out what we are doing to also probably detect the emergency there early and then prevent it from being passed on to other ECOWAS countries. Thank you.
So kindly let's get the feedback. Because of time, please.
All right. So let me just respond to the question. Most of these digital platforms I mentioned were co-created with the relevant stakeholders. For instance, for the timer system, we know that this system will only work if the communities accept it, because the whole system is driven by the community. They are the ones funding it and all that. So before we even started, we had a series of community level engagements with the chiefs, opinion leaders, and all the people that are involved. We had a lot of engagements with them and got their buy-in. And beyond that, when we actually got to the application development stage, we involved them in co-creating together with the Association of Midwives, the gynecologists, and all the relevant, including people from the civil society. So a lot of inputs were made, and because it was co-created, we didn't really experience a lot of resistance at the level of the piloting. Yes, but going forward, when we have to go scale it up, maybe then we may have a few challenges. Yes, but for now, with the piloting, we didn't encounter any significant challenges. Yeah.
Yeah, we'd also appreciate if you have your own bilateral conversations over a cup of coffee or during lunch so that you can get more details about that innovation, which we really appreciate. Enopo?
Okay, thank you very much for your question. So for the other AS countries, we do not engage with them. The engagement is still there, but no longer as ECOWAS, of course. So we are in communication with the Ministry of Health and the NPHs. But like I mentioned, the database that we had, they are part of it. We are still in communication with them while looking for better ways to, bring them on board. And I made mention of the behavioral intelligence and infodemic management system that we are building across countries. When we want to engage them, we won't go as ECOWAS, we engage them through the RCCE network. So we are still in communication with them. Meanwhile, we are looking for better ways, to make it, to crystallize it and make it very official. Thank you.
Thank you so much. I think let's appreciate the panelists, and I believe that this has been quite helpful in terms of us understanding more in what's happening and how best we can be able to better what we are doing. I really take this opportunity to thank you so much for the discussions. I think I've learned quite a lot, and I want, as they stand, maybe you do a group photograph here for your record, for your family record. We normally call it family photos in West Africa, right? So you do a family photo here for the panel. You remember that panel where you sat and you were discussing partnerships? And I can join to balance the gender. So lunch will be served, I think, at the same venue where we had our lunch yesterday. And let's try to eat within the shortest time possible. In Kenya, before we joined the university, we used to go through what we call it's called paramilitary training, the National Youth Service. And one of the things they used to tell us there, that if you are eating, that ugali has no bone. That food, even if it's rice, they say it has no bone, so eat first. But let's try to eat first so that we can come back and finish the remaining part of the session. I know we are running so much behind time, but if you don't want to leave here at 8 p.m., please, let's go back, have our lunch, and come back. Okay? Thank you so much. But the choice is yours.
Colleagues, really, we are, Tete and colleagues, kindly bring the coupons. Give the coupons to people. And colleagues, let's come here a bit early after lunch. It's only 1 hour. Let's come as early as possible so that we can finish the remaining tasks ahead of us. We have a couple of work to do. So let's come a bit early so that we can also go. So Tete, can you kindly give coupon to people? Yeah. And Tete, after lunch, make sure that every partner in this hall, you bring their bags. Yeah, please. Every partner, they bring their bags. Except for someone from, I'm not mentioning names, yeah.
When I wake, I know you are with me. In the dark, I can almost see you clearly. Every day, you sing over me. Like water, my love runs free. Oh, there is nothing like your love. There is nothing and no one above. Oh, come be with us, Holy One. In my pain, I know you can feel it. There I find the comfort in your spirit. Every day you sing over me. Like water, my love runs free. Oh, there is nothing like your love. There is nothing and no one above. Oh, come be with us, Holy One. Oh, come be with us, Holy One. Anywhere I go, in you I find my home. Anywhere I go, in you I find my home. There is nothing like your love. There is nothing and no one above. Oh, come be with us, Holy One. Oh, come be with us, Holy One. Oh, come be with us, Holy One.
Please help this channel by liking and subscribing to it. Thank you.
Hello, hello. Hello, hello. Hello, hello. Hello, hello. Who are the operators, please? Where the mics are not working. Hello? Are you getting me? Can we call our other colleagues? We need to have the panel. Dr. Mariam is supposed to arrange the panel, so can colleagues reach out to her and she can just discuss the panel on surveillance. Who can reach out to Dr. Mariam behind? I didn't even see you. Okay, Mariam, can you come and now call your team members? I didn't, you know, Dr. Mariam, I need to put on glasses now. Don't worry. This shows that I need to put on glasses. Okay, you can come now. This floor is yours. But they should be here by now. Some of them are outside. We really have two presentations to do. Dr. Roland and somebody else will do the presentation, then we move. Samuel, I'm aware that the interpreters are saying they're going for lunch. And then, yeah, they're not around. So, Miriam, you have to help us to interpret. Where? They're coming. Okay. You can come here. Dr. Mariam.
Hello. Please, can you have your seat? So, can we request everyone to enter, have their seat? S'il vous plaît, veuillez revenir et reprendre votre place, s'il vous plaît. Et je voudrais très respectueusement présenter mes excuses pour ce retard dû à l'absence des interprètes. Mais ils sont en route, ils vont arriver très bientôt. Donc nous allons commencer en attendant qu'ils arrivent. So I was saying that I want to apologize for starting late because our interpreters was not in the room. So we already called them, they are coming. So in the meantime, we start with the panel discussion. I will be summarizing the French at the end. But maybe by that time, the interpreters will be in the room. So we are really sorry for this. Sorry for the inconvenience.
Thank you very much, sir. So good afternoon once again. Good afternoon, bonsoir, obrigado. So we are going to be having our panel discussion on the strengthening surveillance, epidemic preparedness and response in humanitarian settings. And apologies once again for starting late. So without wasting much of our time, I'll be calling out the panelists that would be leading this discussion. So in no particular order, we are going to start by calling Dr. Khalifa Kaita, who is the Deputy Director General of Health and Public Services, a public health physician with over 20 years experience in health system management, reproductive health, and program coordination. So Dr. Kaita, please come forward. You're highly welcome. Can we welcome him? Next, we have from Burkina Faso, Dr. Lassani Kafando. Dr. Lassani Kafando is a physician specializing in epidemiology and works with the Ministry of Health in Burkina Faso and also serves as the head of epidemiological surveillance systems within the Directorate of Population and Health Protection. Dr. Kafando, you are welcome. Please take your seat. Next, we have the DG of the Nigeria Center for Disease Control, Dr. Jide Idris. Dr. Jide Idris, yes, he's from a continent called Nigeria, and he has been providing strategic leadership to the country's health, national health security agenda, and also serve as the lead for the implementation of health leadership. Next, we have Dr. Mariam Abdul Karim. Dr. Mariam Abdul Karim, she's from IOM and serves as the regional thematic specialist on migration health from the Regional Office for Western and Central Africa. Thank you very much. So as earlier highlighted, the panel discussion is going to aim at sharing country experiences in the implementation of surveillance and emergency preparedness, as well as response activities in conflict and humanitarian settings. Oh, I forgot, sorry.
Don't forget, let us summarize this in French. Okay. Donc, nous allons avoir un panel pour une discussion focalisé sur la gestion des urgences de santé publique dans un contexte humanitaire. Et nous savons que le Burkina Faso, le Mali, le Nigeria ont une grande expérience en matière de gestion des urgences de santé publique dans un contexte humanitaire. Et donc, nous allons profiter de l'expérience de ces 3 pays.
Thank you very much. So I start by throwing this to the member states that are on the table. Would like you to give us a highlight of the major public health events that are currently affecting the conflict, the public health events that are currently happening in conflict-affected areas, especially in your country, and what surveillance approaches that you have undertaken that has been proven to be effective, especially for those specific conflict-affected areas.
Et donc, la première question, c'est de savoir comment vous vous organisez pour la gestion des urgences de santé publique, mais également la surveillance en santé publique dans le contexte humanitaire que traverse votre pays.
Ok, merci bien. Nous sommes très heureux de partager l'expérience du Mali en matière de surveillance, de préparation et aussi de réponse aux urgences sanitaires dans le contexte de crise. Vous n'êtes pas sans savoir que le Mali, depuis 2012, vous allez traduire, hein? Parce qu'ils ne sont pas là. Hein?
Oui, je vais résumer
okay.
à la fin, mais comme j'ai la parole, peut-être je vais traduire l'introduction. So Mali is very, very happy to share their experience. So you may know that since 2012, the country is facing a challenge in terms of conflicts in some of the areas.
Voilà, donc je disais que le Mali connaît depuis 2012 une crise multidimensionnelle qui a mis à nu notre système de santé dans le temps, et c'est ce qui nous a amené chaque fois à repenser à des stratégies pour pouvoir assurer le minimum que cela puisse représenter. Donc dans ce cas précis, actuellement nous avons sur nous 4 menaces majeures. Il s'agit là du déplacement des populations, parce que dans toute crise, vous convenez avec moi que ce sont les populations qui font les frais. Ces populations se déplacent, et alors que les soins de santé doivent aussi suivre les populations dans leur déplacement. Et face à cette menace, la conséquence, c'est ça va agir tout de suite sur la couverture vaccinale, qui fait que nous avons enregistré beaucoup d'enfants 0 dose. Et la conséquence, c'est que nous allons enregistrer des épidémies. Actuellement, hier, nous l'avons vu dans la présentation, le Mali a notifié des cas de diphtérie, des cas de rougeole, des cas de mpox, et c'est cet ensemble-là qui fait aujourd'hui que nous faisons face à ces menaces. Mais ce que nous avons développé pour pouvoir répondre à cette question, c'est que nous avons mis en place un système de surveillance avec l'implication de la communauté. Et cela à travers les réseaux de surveillance de proximité, en s'appuyant sur la stratégie surveillance à base communautaire. Il faut savoir que cette surveillance est maintenant fonctionnelle dans les 75 districts de santé au Mali, et elle est tenue par les ASC qui sont au nombre de 55 000 à peu près, et ces ASC sont accompagnés par les relais et les plateformes communautaires. Donc, pour être rapide et et que les informations puissent être transmises à temps, les données à temps, nous avons pensé à mettre en place une plateforme, c'est-à-dire la digitalisation de la santé communautaire à travers le DIS Mali, qui est interopérable avec le DIS 2. Donc l'ASC, il saisit les informations sur la tablette ou bien le smartphone, et il peut même saisir hors connexion offline. Mais dès qu'il entre dans la connexion, il a tout de suite les informations sont basculées tout de suite sur la plateforme Disque Mali et aussi sur Disque de ECC, qui fait que nous avons tout de suite l'information. Mais il se peut aussi que, compte tenu de l'urgence, qu'on puisse utiliser d'autres moyens informels, tels que les messages WhatsApp, les SMS, qui permettent à l'ASC, aux agents de santé communautaire, aux relais, de donner tout de suite l'information. Et c'est ce qui fait que nous avons un système de surveillance épidémiologique qui nous permet vraiment d'identifier, de détecter rapidement les événements de santé, les maladies, et dès qu'on a ces informations, il faut vérifier, il faut évaluer la situation. Et pour ce faire, dans un contexte de crise, il est important que localement, que les capacités soient renforcées. Renforcées en ce sens qu'au niveau local, que l'équipe sur place soit capable de vérifier l'information, de procéder à l'évaluation et aussi à prendre les bonnes décisions dans ce sens. Et pour ce faire, nous nous sommes basés sur les équipes d'intervention rapide qui sont déployées dans les 75 districts. Et si je ne me trompe pas, nous avons formé à peu près 117 équipes d'intervention rapide. Et en plus de ceci, nous avons profité de la formation épidémiologie d'intervention de terrain, les FLTP, où nous avons formé en tout et pour tout 454 FLTP à des différents niveaux. Le frontline qui représente 345 agents. Ces agents sont au premier niveau, au premier contact. Et c'est ce qui fait que nous avons généralement des notifications. Et ces notifications-là sont suivies d'investigations parce que c'est des gens qui ont déjà la capacité de notifier et d'investiguer et ensuite orienter les prises de décision. Nous avons le niveau intermédiaire. Ces niveaux intermédiaires, nous les avons mis au niveau district sanitaire parce qu'ils ont une certaine compétence qui peut appuyer le premier niveau par rapport à l'évaluation et par rapport à la vérification même de l'événement de santé en question. Il est aussi important de noter que nous avons des niveaux avancés qui sont au niveau régional ou au niveau central. À côté de la formation FLTP, nous avons la formation FIM aussi, qui nous a permis de former à peu près 123 agents et qui évoluent sur le terrain en termes d'intervention. Voilà un peu ramasser ce que nous faisons de façon globale, l'expérience du Mali, mais ce qu'il faut retenir, c'est que en situation de crise, il faut toujours mettre la communauté au centre de la notification, au centre de la détection et au centre de la riposte. Si nous parvenons à faire ça, nous avons fait un grand pas. Parce que les stratégies traditionnelles, les vaccinations en centre fixe, en équipe mobile ou en stratégie avancée, ne payent pas souvent et il est souvent important avec la communauté de négocier des corridors pour pouvoir mener les différentes interventions de santé. Voilà un peu ce que je peux dire par rapport à ce que le Mali fait depuis 2012 et nous avons des insuffisances, mais nous sommes en train de les prendre en charge petit à petit. Peut-être que le long de nos discussions, nous allons parler des défis qui s'opposent à nous. Merci.
Thank you so much, Mali. So to summarize, we know that Mali is facing this conflict since 2012. And the main challenge that the country has is the movement of the population. So with that movement of the population, one of the applications is the vaccination process. So because of this movement, they do have zero-dose children, actually, that they are trying to address. And they have some of the outbreak, like diphtheria, mpox, and measles, that are ongoing. So to address this, how do they organize themselves? They focus everything on the community. So they develop community surveillance. And the country has this community surveillance in 57 districts. And they train the community health workers, and they use a platform that they call DH Mali, which is linked to the DIH2. So those community health workers are able to collect data and to introduce this directly to the platform. But they also use message by using their phone. They can also send message from the village level. They also use the FLTP frontline, intermediate, and advanced resources. So they do have about 454 trainers. Frontline is about 347. And so the frontline, they are the one who verify the event. You know, if we take EBS, the first is the signal detection. So when they detect the signal, they go for triage and they will go for verification. For verification, we need more experienced specialists. So the frontline are the one doing this. The intermediate are at district level, and the advanced are at regional and central level. They also have a FEM. A FEM is those who had that training, the 6-month training for public health emergency management. And want me to talk about that today. So they have 123 FEM that are also supporting this process. So to summarize, during a crisis, during a conflict setting, the advice should be to put the community on the center of all the approach. So when the community is involved, that's what's helped them to address surveillance and other emergency preparedness and response in the country.
Very much, Ardi. So to move on quickly, we move to Burkina Faso. Maybe you give us a brief on the roles of community, the role of community surveillance in detection and reporting, as well as response when it comes to humanitarian affected settings in Burkina Faso.
Et donc, nous allons au Burkina Faso pour que vous puissiez nous expliquer en détail, comme vient de le faire le Mali, le rôle de la surveillance au niveau communautaire, au niveau de la détection, mais également au niveau de la gestion des urgences de santé publique.
Briefly.
Ok, merci beaucoup. À l'instar de Merci bien pour la parole. Il faut dire que à l'instar du Mali, depuis 2018, le Burkina Faso connaît des défis sécuritaires. Dans le pays, nous disposons d'un système de surveillance et d'alerte précoce qui prend en compte les deux dimensions de la surveillance, notamment la surveillance basée sur les indicateurs et la surveillance basée sur les événements. À ce titre, chaque semaine, les données provenant des formations sanitaires, y compris les formations sanitaires qui sont dans les zones d'accès difficiles, sont transmises pour être analysées. Et dans le cadre aussi de la surveillance basée sur des événements, tout événement qui est enregistré, y compris dans les zones d'accès difficiles, sont transmis immédiatement afin que l'évaluation de risque puisse être menée pour décider de la conduite à tenir face à l'événement identifié. Les menaces, comme l'a dit le Mali, c'est les déplacements de population qui font qu'on assiste dans certaines zones d'accès difficile à des flambées de cas de maladies à potentiel épidémique et c'est surtout les maladies évitables par la vaccination. Nous avons enregistré dans certains districts d'accès difficile des flambées de cas de rougeole et le SGI a même été activé pour prendre en charge cette flambée dans les districts à défi sécuritaire, notamment dans 5 districts d'accès difficile. L'une des difficultés, c'est vraiment le déploiement des équipes d'intervention rapide dans le transport des échantillons dans les zones d'accès difficiles, et ce qui a conduit à renforcer la participation des acteurs au niveau local. Au niveau local, les acteurs participent à la remontée des informations dans le cadre de la surveillance basée sur les événements pour que les informations puissent remonter. L'un des aspects que nous avons pris en compte dans cette surveillance, c'est l'implication des services de santé des forces de défense et de sécurité et que nous avons capacité dans le cadre de la surveillance intégrée de la maladie et de la riposte, mais aussi dans toutes nos formations en lien avec la surveillance, ils sont pris en compte, notamment la formation FTP, et ça nous permet que les acteurs, notamment les cliniques mobiles de ces forces de défense et de sécurité, puissent prendre en compte les aspects de surveillance et de détection des événements. Un mécanisme spécifique de transport des échantillons dans les zones d'accès difficile a été défini en partenariat avec un certain nombre de partenaires des Nations Unies pour que des échantillons pour la confirmation puissent être transportés, acheminés à travers UNICE, le système des Nations Unies, l'hélico du système des Nations Unies, mais aussi à partir de convois sécurisés. Pour dire que tout est mis en œuvre avec la participation des acteurs au niveau local pour que la détection puisse se faire, y compris l'utilisation des forces de défense et de sécurité. Et tout comme au Mali, il faut dire qu'il y a la réserve sanitaire. Environ 100 experts ont été formés à l'échelle du pays en gestion des urgences, pour essayer de faire le maillage à l'intérieur du territoire. Il y a aussi des sessions de FEM qui sont organisées à l'intérieur du pays et cela prend en compte les acteurs dans les zones d'accès difficiles et pour que, si une situation venait à naître, que les acteurs au niveau local puissent assurer l'investigation, l'évaluation des risques et définir de la conduite à tenir. Donc il faut dire que tout est organisé de telle sorte que les acteurs au niveau opérationnel n'hésitent pas à pouvoir détecter, à transmettre, mais aussi à évaluer le risque et à définir l'intervention appropriée. Et lorsque il y a nécessité, le niveau central, le système de gestion des urgences est activé pour apporter la réponse. L'un des mécanismes aussi qui permet de suivre, c'est qu'il y a un système de gestion des incidents qui est activé en permanence pour regarder les zones à défi sécuritaire, notamment un incident manager nommé pour les zones à défi sécuritaire pour pouvoir regarder et faire en sorte que nous puissions assurer la préparation, la surveillance et la réponse dans les zones d'accès difficile. Donc voilà un peu de façon en résumé les points sur lesquels je pourrais aborder en attendant de revenir en détail sur les éventuelles questions.
Thank you. So, similar to Mali, Burkina Faso since 2018 is also facing the same challenge in terms of conflict, and some of the area are difficult to access. So they also develop a system of surveillance based on the alert and also event-based surveillance, but also indicator-based surveillance. So the main challenge is the same with Mali, the movement of the population and how to access those population. So some of the area are very difficult. So to address this, they have a collaboration system with the army, you know, the physician and the nurses that are part of the army are part of the system. So the army help them for the deployment of health workers in the areas that are so difficult. So in terms of data collection, they also have the community health workers that are helping to detect the signal, and those signals are directly submitted at central level. And in terms of verification, they also have the FLTP, FEM, intermediate, frontline, and advanced staff that are there to verify. So in general, the difficulty is the accessibility of those areas and the security issue, but they are managing with the support from the army.
Thank you very much for providing that perspective from Burkina Faso. So we quickly move on to Nigeria. So sir, I would like you to briefly talk about...
Please, it seems like we have the interpreters back. Are you ready to take the lead? Okay, thank you so much. So,
okay, so we can use our
we can use our hand now. So nobody appreciates my interpretation. Hey.
Okay, so in case you are not aware, the clap is for Dr. Kuku, not for the interpreters. It's for Dr. Kuku, actually, not for you. Not because you are back, because he's been supporting us with the translation, so we are clapping for him. Another clap for my RDs, please. Thank you. Huh? Okay, so we move on to Nigeria, and please, DG, maybe you provide us with an insight, especially when you look at emergency preparedness plans that are adapted for conflict and humanitarian affected areas, but also maybe you talk about the operational challenges and especially around logistics and operations during outbreaks in humanitarian affected areas, and the continuity of surveillance and laboratory services on those affected areas.
Can you come again? I lost you.
Okay, so I was asking if you could briefly provide an insight into the operational and logistics plans that you have for areas that are affected for humanitarian crisis, especially with humanitarian crisis, especially when you look at surveillance and emergency preparedness in those areas. So what are the plans that you have to enhance surveillance and emergency preparedness in the affected areas, and the challenges as well? Thank you.
Well, thank you very much. Well, like many of us know, Nigeria over the past couple of years has had its fair share of conflicts and humanitarian problems. And by virtue of the nature of these conflicts, there are certain things that are specific based on dysfunction and other things that are as a result of the conflicts. One of them, one of these are for direct conflicts. You have specific injuries. You have displacement. You have mental health issues, gender violence, etc. But more importantly, again, as consequences of this, you have these epidemic-prone diseases. And let me tell you, in most of these conflict-ridden areas, at least we have at least 8 of these epidemic-prone diseases. You have Lassa fever, which is getting ground. We have Mpox, whatever it is. You have cholera, measles, resurgence of diphtheria. You have dengue fever, yellow fever, etc. But so you can relate some of this is to take, for instance, like measles and diphtheria. These are a reflection of the gaps in vaccination or immunity, and especially when people are displaced again, they tend to lose some of this. You have Mpox, which is basically maybe due to migration or movement of people from different areas to other parts of the area. Cholera, we all know, is wash-related, and mostly from displaced people because they don't have those infrastructure. And of course, Lassa fever. So with respect to surveillance, the strategy is more like using a multi-hazard risk assessment for some of these. And these are done again, you do in preparation for some of these things. You look at the risk involved in those areas, and you tend to develop your preparedness plans. And basically, what kind of resources will you need? What kind of infrastructure? What kind of material there before you move to logistics? So basically, that's that. For surveillance, I think the best method is using all, like I said, all hazards, with a combination of surveillance. And for those hard to reach areas, again, you do things like community surveillance, and therefore you have to use local informants, local village heads, village leaders, religious leaders, and of course in some areas again you have some healthcare workers there. Those are people again have been trained in how to pre-trained in how to use collect data and provide this treatment. But in addition to event-based and community-based, where you can use the normal surveillance activities, and of course for detection, you set up these sample transport systems, both intra and inter, depending on the capabilities you have there. And for those hard areas, like my colleague had said again, use the services of the military, the national security agencies, they provide you cover. And of course, we have the support of our donor agencies or humanitarian services. I would take like MS, I think MS, all right? No, apart from IAM, we have Dr. MSF, sorry, MSF, IAM, etc. You have UNICEF. They take different aspects of this. So it's more like a combination of efforts. And of course, where you have the laboratory services again, we've tried to use mobile laboratory services again, especially for some of these, for basic bacteriology and virology. You don't do the other things. But in terms of preparedness, I think over the years now we learn to prepare in advance. You map those areas again, you map the resources you have, and you think of medical countermeasures, what would you need, how do you pre-position, and of course, in trying to go into those hard regions again, use the military, use all those people there who can provide support, who can provide cover, and who can provide protection for you. More importantly, as part of preparedness, you train people, and there are quite different levels of training. In some areas where you have already trained MFLT, you use their services. In other areas where you train, you train some of those first, the village health workers, the DSNOs, etc. There's remote training where you have, where you can use mobile facilities. Where you can't, you just determine, looking at the social structure of those places, the traditional leaders, again, you've thought again, you can communicate with them and see how best they can do that. And that's what we've done. So more like a combination of this event-based, community-based, and the standard, of course. So about the laboratory for detection, we have a tiered system in Nigeria. And of course, at the grassroots level, again, those are the things that provide the basic diagnosis facilities. Where you need urgent ones, again, use the normal, the standard referral, sample referral system we have, to go to specific laboratories where they have the capability to do that detection. In terms of challenges, like Riley said, for hard to reach areas, one is the issue of access to services, again, for the people. You have the issue of workforce, like we've said the last couple of days, workforce issue is an issue. You have logistics, because it's one thing preparing, it's another thing getting your materials you need to the various locations, again, in terms of transportation, road facilities, etc. So you might, at times again, we have to use the services of the military in these ones. Like capacity, data quality is one. So what we tend to use, again, use some of these, we use the mobile applications, like there's the early warning systems that local people are trained on how to identify some of these things, and again, they have a way of communicating to that. And basically, if you start seeing increases in number of deaths, maybe illnesses, again, it's a trigger for you, again, to get the local heads, again, to address, to get in contact with you. They pull all this together and notify the public health agency. The issue of coordination is key. And that's why, again, that most people, again, is part of the preparedness. You have local leaders you use, and you train the local leaders from different areas. You train healthcare workers, you train the data collectors, again, what they do. Everybody knows his roles, his roles and responsibilities, what they do. So that people, and of course, the other one is continuity of service because of displacement. That's a major issue. Continuity of service, again, and that's why, again, people tend to develop those IDPs, again, in cities when they move all those people, again. And the other thing is provision of water, provision of all those facilities are major issues, again, that actually increase the rise in these diseases. I don't know if I answered your questions.
Yes, you have provided great insight into the plans, the all-hazard plans that is being adopted in Nigeria in the conflict-affected areas, but also identify the challenges that are affecting surveillance and response across these areas, which I think cut across also all the member states that are affected by this challenge. So once again, thank you very much. I move on to Dr. Mariam. Maybe Dr. Mariam, you give us an insight into how regional institutions like your institution, the IOM, can provide better support to member states, especially looking at population movement across borders and cross-border surveillance, but also when it comes to support for laboratory and emergency response services. Thank you. Over to you, Dr. Mariam.
Thank you very much. Thanks again for the invitation and particularly for having me in this platform. I must say over the years, since I've been in the region, I've been coming always on the emergency desk, and often the same countries come again. So it's a concern, and I know that member states, really I wanted to thank member states sitting at this table on the effort that they have been doing to really help people. And I see in all three interventions that the issue of human mobility has come out clearly. Yeah? So displacement of population is actually an issue. I would like to perhaps relate to my answer by mentioning the fact that regional institutions, and those in this room as well, have in fact a critical role in helping member states from policy commitment to practical and interoperable preparedness arrangements, particularly when we're talking about cross-border initiatives. So, and I would not say much about the fact that we've reiterated several times here that disease have no borders. So if there is an event in one point in our region, that means it's a concern for all of us. And if it is beyond our region, then we should really remain ready to see, not that we wish that it comes to us, but we should just be ready so that if there is anything that comes, we can go. And how can this regional institution help? I think in 3 points, I would say regional institution can be the conveners, you know, and what do I mean by conveners? To bring neighboring countries and sectors together around common risks and shared mobility corridors. The second point is about evaluate and strengthen the existing capacity. We've mentioned that this morning and yesterday as well, that there are capacities that are in place, and therefore any opportunities that we have to enhance would be something that everyone would appreciate. And when we evaluate, we have to look into identifying, you know, the gaps, especially for IOM, it will be along mobility. So it's going to be around border communities and host communities. Communities were mentioned by all three interventions at the table here as well. And then support SOPs, information sharing mechanism, so that the preparedness approaches are actually strengthened. And then the third point I wanted to add in my answer, just to be brief, we have to test whatever it is that we're mentioning, you know, and these tests are actually happening. You know, you have the CMEX exercises and the evaluations, as well as, you know, joint preparedness planning before the emergency occurs, because often when the emergency strikes, the time for preparedness is over. Let me stop here. Thank you.
Yes, I think that is a key one. When emergency strikes, time for preparedness is over. So we need to be prepared before the emergency strikes. To round up this discussion, I would like to have a proposal on recommendations on how to improve cross-border preparedness and information sharing, because the three countries seated on this panel discussion have all mentioned population mobility as an identified challenge when it comes to surveillance in those settings. So what recommendations do you think you can provide, and how do you also see the regional bodies, but also the national partners, how do you want them to intervene to support surveillance and emergency response across those areas, especially when you look at population mobility? So we start with Mali, briefly, please.
Ok, merci bien. Si le Mali a des recommandations, c'est des recommandations à l'adresse d'abord de nos pays en matière de surveillance transfrontalière. Et je pense que nous nous sommes préparés à ça. Je voudrais comme exemple le premier cas de Mpox au Mali, ça a été confirmé à Kouré-Malé. C'est la ville qui fait frontière avec la Guinée. Et après investigation, nous nous sommes rendus compte que le cas est venu de Sigiri. Et tout de suite, nous avons pris contact avec l'équipe de district sanitaire de Sigiri pour leur donner l'information. Et après investigation, nous nous sommes rendus compte qu'il y avait des sujets contacts et qui ont été suivis. Donc, dans les deux pays, et en Guinée et au Mali. Ça, c'est des exemples de collaboration transfrontalière. Nous en avons aussi avec le Burkina, surtout avec, dans la zone de Koro, la zone des 3 frontières. Et nous sommes permanemment en contact. Dès qu'il y a un événement de santé, l'autre partie est tout de suite informée et les décisions sont prises ensemble. Et c'est ce qui fait que, malgré le conflit, au niveau de ces frontières, nous avons moins d'événements qui nous dépassent et que nous n'arrivons pas à circonscrire. Mais sur le plan régional, il est important comme recommandation d'harmoniser les approches. C'est d'organiser des réunions de haut niveau entre les différents pays comme cette rencontre. Ça permet d'échanger les expériences, mais aussi aller plus loin pour harmoniser les différentes approches. Aussi préparer et prépositionner, c'est-à-dire faire des plans de contingence dynamiques et qui nous permet non seulement de nous préparer, mais aussi de prévoir tout ce qui peut être effectif. Dans ma première intervention, je n'avais pas parlé d'un certain nombre de défis, mais il est important aujourd'hui de renforcer le diagnostic parce qu'au niveau de nos régions, au niveau des districts sanitaires, nous avons des capacités de laboratoire très limitées qui nous amènent à des défis de transport des échantillons. Et si sur le plan régional, les différents pays peuvent être accompagnés à renforcer les laboratoires, ça sera une très bonne chose. Et continuer à appuyer toujours les formations en FLTP et en FEM. Et si possible, appuyer les États à mettre en place des fonds permanents de lutte contre les épidémies et catastrophes afin d'aider les pays qui notifient, qui confirment des événements de santé en attendant que tout le monde soit au point. Si nous avons ces prépositionnements, ça nous permettra d'avancer, surtout en termes de médicaments, d'intrants, des équipements de protection individuelle. Ces éléments pourront nous aider à avancer sur le plan régional. Voilà un peu les quelques recommandations que je pouvais partager. Et ces recommandations s'adressent non seulement aux pays, mais aussi aux institutions régionales, afin que nous puissions avoir une approche beaucoup plus intégrée, une approche qui va nous permettre de se soutenir et de s'accompagner quand on fait face à ces événements de santé. Voilà un peu ce que je pouvais dire. Merci.
Merci beaucoup. Thank you very much. So we move to Burkina Faso.
Ok, merci beaucoup pour la parole. Je vais revenir sur un certain nombre d'aspects en termes de recommandations. Il faut dire que l'une des recommandations, c'est le renforcement de la surveillance transfrontalière. Et on doit pouvoir renforcer cette surveillance, le partage d'informations. Et comme l'a dit l'acteur de l'OIM, on doit pouvoir se retrouver pour des exercices de simulation, voilà, sur table ou grandeur nature, pour mieux se préparer en attendant que les situations complexes n'arrivent. Il y a également le développement de plans de préparation conjoints. Je pense qu'on l'a expérimenté avec un certain nombre de pays, notamment le Mali et le Niger, dans le cadre du MPOX, pour pouvoir un peu harmoniser les approches et se préparer pour mieux faire face aux jeux en santé publique. Il est ressorti pour ce qui concerne les capacités en ressources humaines. Il est essentiel qu'on puisse continuer à renforcer les capacités ressources humaines pour la formation des acteurs. Plus vous avez des ressources humaines compétents et mieux préparés, ils peuvent faire face aux différentes situations. L'un des éléments, c'est le mécanisme de transport des échantillons dans des zones d'accès difficiles. Je pense qu'avec l'UNICEF, il y a un travail qui est fait pour accompagner, par exemple, les pays et pour que les échantillons qui sont collectés au niveau, par exemple, des zones d'accès difficiles, qui puissent être convoyés, voilà, pour la confirmation. Mais aussi dans le cadre de la réponse, pour pouvoir acheminer, par exemple, les vaccins, voilà, on a besoin qu'un certain nombre puisse nous accompagner dans le cadre, par exemple, du système des Nations Unies. Un point important, je pense qu'avec l'UEMOA, ces questions ont été discutées, et notamment la nécessité qu'il y ait des fonds d'urgence pour pouvoir accompagner les pays. Parce que l'un des défis aussi, c'est à ce niveau, c'est lorsque la situation survient que les acteurs recherchent maintenant de l'argent pour faire face à la situation. Donc voilà les différents points sur lesquels ça peut faire l'objet de recommandations. Les recommandations que déjà certains pays ensemble, notamment le Mali et le Niger, que nous entamons un certain nombre de réflexions ensemble pour pouvoir notamment élaborer les plans de préparation conjointe, harmoniser nos directives, par exemple, de surveillance, voilà. Mais il est attendu aussi qu'il y ait vraiment l'accompagnement des partenaires pour ce qui concerne un certain nombre de goulots d'étranglement pour renforcer la préparation et la surveillance. Merci.
I think the essence of gathering here is more of collaboration and sharing knowledge, sharing experiences. And so basically, like most of my colleagues have said again, you know, in preparedness, there are plans you make, there are contingency plans you make, and you know, you do all the risk assessment. I think this can be jointly done by different parties. Risk assessment, contingency plans, etc. And secondly, join forces again in terms of cross-border surveillance. You share information, you share data. And of course, when you go visiting again, when you go assessment, you can go together depending on that. And each team has its own strength, but you can all share again when you get to that particular area. Throughout today, you've mentioned capacity building. There are different countries, different states, different partners, you have different resources. If we can share, people sharing knowledge, sharing information, sharing data, and sharing knowledge and data information, I think it's the people that are better for it. Building capacity training. So the last one, like somebody said, again, diagnostic support. I remember that sometime last year, there was a request from, I forget the West African country now, to help them in doing genetic sequencing of some of their samples, which we did very well, and they were better for it. So in that guide, again, that way, again, you can do all the diagnostic sharing, support for those of them, those countries who have the capabilities and those who don't have, we can all share again and help build knowledge and capacity again. Contingency fund, and this is what we started doing again in Nigeria before. Once we have the outbreak, you start looking for money. But now, making it law, or trying to create a legal platform for contingency fund to be released again. So that's pre-planning, it's part of preparedness again. You start planning for these funds again, so that it's not only when you have that event that start looking for funding. So these are things, again, experiences you can share with our partners in different regions again. I think we've all said everything. Logistics, operations, I think our partners are better at certain things. Where we there, we can address technical issues. They can help us with access to various areas. They give us information like IOM, movement of people information, movement information, so migration information, and they can share all these things together again for us to better prepare for whatever emergency we create. Thank you.
Thank you very much. So, Dr. Maria, maybe we can also provide more perspective on how other regional bodies can support with regards to surveillance and emergency response amongst the population that regularly move. I know this is your area of expertise, so maybe you can tell us how other partners can also come in to support the detection and response to disease events or public health events in those populations as they move. Thank you.
Sure, thank you very much. Before getting into answering that question, I just wanted to emphasize on the fact that we all believe that, effective coordination requires agreed mechanism for information sharing, referral, and joint preparedness before an emergency occurs. And not only once an outbreak is happening or is underway. At IOM, we have this health border mobility management, and this framework supports the whole of government and the whole of society approach, and in multi-sectoral coordination, which includes member states, Ministry of Health, regional institutions, civil society, and local authorities, etc., etc. It brings together health authorities, but also border management actors, communities, humanitarian partners, and other relevant sector around communicable diseases, for prevention, detection, and response along the mobility continuum. The cross-border surveillance works best when it actually reflects the actual population movement and the mobility corridor. We see now, in the ongoing response in DRC, how every week when we get the data, how we're able to see, the epicenter is still there, but luckily, on the Uganda side, the outbreak has been declared over. But at the same time, from IOM perspectives, what we have been looking in the phenomena there, and luckily, we thank partners for putting in enough resources to try to curb the disease. Over the more than 200 point of entries and point of controls that we have been looking at, the cross-border information sharing and preparedness are actually helping for the surveillance. But then it also means that, we have to look beyond the health sector, We have to look into, as I mentioned earlier, immigration, border authorities, transport actors, One of the area that now, through risk communication and community engagement, is the practices on burial. Despite the information that is being shared, if people keep on carrying certain practices, then whatever it is we're doing is not helpful. What is it? One of the innovation, or maybe one of the lessons that we learned, and here the director of NCDC mentioned earlier, and from mobility aspect, I would say surveillance system needs to embed mobility. We move, we're human beings, we move with our cattle, we move with our children, we move with our cars, and this is the reality. In this room, we have countries that have lots of nomadism activities, and we've been mentioning One Health and so on. So mobility needs to really be embedded into our national plans. Communities have been mentioned by colleagues. They need to be part of the surveillance. Community-based event surveillance has to be there throughout. Preparedness must be multi-sectoral, and that should be before an event occurs. Borders and hard-to-reach areas requires deliberate investments. My colleague here on the table just mentioned, that emergency funds need to be there as well. And that means, these hard-to-reach areas should not be hard to reach by the time we have an emergency. And then on the mobility aspect, I still have 3 points. I think better mobility and migration data is required. There are some data. You may ask IOM to provide you with data of people on the move, but then since we're not a health agency per se, the data will be disaggregated according to the mobility aspects. How many people have crossed to this place to the other place. But it's up to us here to see how best we can look into we can look into how to integrate health indicators that can be collected so that, we have them ready and these can be embedded into national programming. Institutional capacity building. We all mentioned about capacity building during outbreaks here, so we really have to maintain that because we know how the workforce changes as well as we go. And then last but not least, regional preparedness should follow mobility realities while remaining nationally owned. Thank you.
Thank you very much, Dr. Mariam. I totally agree with you. So I would like to use this opportunity to thank our panelists for the valuable contributions. And I'm sure everyone in the room will agree that from the discussions today, it has been demonstrated that conflict and humanitarian emergencies requires us to rethink how we approach surveillance, but as well as emergency response in areas that are affected by the conflict. So from these discussions today, I would like to summarize the few key items that came out of this discussion, which are the use of community surveillance systems or community surveillance officers, but also they need to have emergency funds, both at the national and the regional level, so that we are proactive, not reactive. Another key point is the issue of population movement, which I'm sure does not only affect the countries that are affected by conflict, but there is also a massive movement of population across member states that are not affected by humanitarian crisis. Additionally, what came out clearly was the issue of cross-border information sharing and collaboration, which I am sure is a key item for Africa CDC, and Africa CDC has been championing on the cross-border collaborations and information sharing. The use of security agencies or security officers to support surveillance in communities that are affected by humanitarian crisis is also came out as a very important point from this discussion, but also One Health collaboration and the need to have laboratory services at the subnational level to prevent the transportation, long-distance transportation of samples across the countries. So once again, thank you very much, our panelists. Do we have any contributions from the room? Anyone? Let's take 1, 2 contributions or questions or comments based on what have been discussed. Anyone? Yes, one. Okay. Do we have another one? Let's take 2. We already have 1. Okay, we have 2. Okay, thank you. So you start.
Ok, merci. Merci aux panélistes. Nous avons comment la surveillance se fait dans leur pays malgré les conditions d'insécurité qui sévissent. Mais nous n'avons pas senti l'implication de la santé animale et de l'environnement dans cette surveillance. Qu'en est-il dans vos zones? Merci.
Okay, so I think that is a question from a veterinarian. Anyone to provide that response? Using One Health approach in humanitarian setting? Nigeria wants to provide a response to you.
Yeah, I mean, let me say most of the problems, the diseases we see are zoonotic diseases. So you're going to approach it from the One Health perspective. And this is where the issue of collaboration comes in. But I must say that with respect to some of the diseases we see, that One Health issue is a bit, I would say, needs to be beefed up with advocacy. And most times, again, it's at the sub-national level towards the, at the community level. So what we're trying to do is get the ministries of agriculture, environment, and then I think livestock to get fully involved here. It's a bit difficult, but it requires serious advocacy because everybody tends to work in silos. So we have to break that barrier. And right from the beginning, again, I think it's better from the community itself, community leaders and communities, you can get it better done because they will lead, because that's where they are. Thank you.
Very much. Dr. Aime, what is your question, please?
Ok, merci beaucoup. C'est juste une petite préoccupation. Nous remercions les panélistes pour la qualité des échanges, des informations partagées avec nous. Et je pense que dans le contexte qui est décrit là, c'est beaucoup de stratégies innovantes qui sont mises en œuvre vraiment pour garantir la continuité des soins et sauver des vies. Mais dans le même temps, tel que c'est décrit, c'est qu'il y a quand même des ressources humaines qui sont mises à contribution. Et nous savons déjà qu'en temps normal, travailler dans le système des urgences, ce n'est pas facile. Maintenant, dans ce contexte particulier de conflit, d'insécurité, je voudrais savoir s'il y a quand même des stratégies innovantes pour vraiment encourager le personnel impliqué dans les activités dans ces zones et comment les maintenir. Parce que ce qu'on sait, si c'est des agents de l'État, comme chez nous ou dans d'autres pays, souvent les gens cherchent à quitter ces milieux. Comment vous arrivez, s'il y a des petites stratégies, je pense que c'est mieux de partager aussi avec nous autres pour qu'on puisse vraiment comprendre tout l'effort qui est fait pour garantir la sécurité aussi de ce personnel qui travaille dans ces milieux d'insécurité et autres. Donc ma question s'adresse à l'ensemble des trois pays, juste pour avoir vos expériences. Merci.
You can respond to that.
Ok, merci bien. En fait, nous l'avions dit, parce que nous nous sommes dit, pendant la crise, le personnel qualifié, compétent dans ces zones, attend quitter ces zones-là. Et pour pallier à cette situation, nous avons développé la stratégie de former les agents qui sont sur place, les renforcer en capacité, et si nous arrivons même à recruter, le recrutement se fait localement. C'est pourquoi même par rapport aux ASC, aux agents de santé communautaire, ces agents-là sont recrutés au sein de la communauté. Si la communauté se déplace, ces agents-là se déplacent avec la communauté. Mais si c'est un personnel qualifié, compétent, il faut qu'il soit de la zone et en ce moment, on les renforce. Mais il nous arrive souvent qu'on enregistre un événement de santé dans une région, dans une localité, où le personnel sur place n'a pas la capacité nécessaire. il nous arrive souvent de gérer l'événement de santé à distance par délégation. Je voudrais, dans la région de Gao, il y a une zone aurifère, il y a eu une épidémie de Stras, mais c'était sous le contrôle des terroristes. Sur place, le DTC, le chef du centre de santé qui était sur place, n'avait pas la capacité d'investiguer et procéder à l'évaluation. Nous avons consulté une équipe à partir de Bamako avec des experts épidémiologie, des laboratoires, avec des experts de l'OMS pour se déplacer carrément sur la région. Mais nous avons voulu que cette équipe soit jusque sur le terrain. Mais compte tenu de la situation sécuritaire, ils étaient bloqués, malgré que les forces armées avaient proposé d'accompagner l'équipe. Nous nous sommes dit que ça va être trop risqué et nous avons échangé. L'équipe a travaillé à distance avec le personnel sur place et les prélèvements conduits sur la région de Gao où les premières analyses ont été faites. Voilà, c'est la flexibilité opérationnelle qui est demandée ici en fonction des contextes. On agit. Soit le est compétent, on le laisse faire, mais dans le cas contraire, on les appuie. Merci.
Thank you very much. So I think we are done with this session. Abra, can we have a picture for the panelists? Thank you very much. SRR, please, can you join them for the picture? RD, can you join them for the picture, please? The ReTAC chair, can you join them for the picture as well? Abdullah, is this you? Is you? Calvin? Is it Calvin?
Good afternoon. Can we stretch again? Somebody was about to have a muscle pull some few minutes ago. Can we just stretch? Just stand. Let's just stand and stretch. Just stand. Stretch. No. Just stand and stretch. Just stand. Okay, let's stand. We are not going to stretch. Just stand. Because we've been sitting for quite some time listening to presentations. Just stand to your left and greet your neighbor. Stand to your left. Left and greet your neighbor. Left. Left. Some people don't know where their left is. Where's your left? Is this your left? Turn to your left and greet your neighbor. Yeah? Okay. Thank you so much. Let's have a seat. That we are really pressed of time. We've been sitting, been listening to presentation, we've been engaged, and the elections also to be held, right? So I've just consulted further, and we are saying that we move to elections. We move to elections, right? So I want to take this microphone to Habiba, Dr. Habiba. Yes.
Here, there we go. All right, good afternoon, everyone. Thank you for having me again. So this is the time to elect your new bureau. The elections will be conducted, well, facilitated by me, but only member states will be allowed to vote. But before we proceed to that part, I wanted to explain to all ReTAC members the voting procedure as per the rules of procedure that you have adopted in May 2025. So to begin with, like I said, only member states are eligible to be voted as chairperson and vice chairperson, and only they vote. So no one else is allowed to participate. There will only be one vote per member state, and according to the rules of procedure, we do the elections based on the principle of rotation, which means any member state that has been or is currently chairperson or vice chairperson cannot run for re-election. Another rule that we have at the AU generally is any member state that is suspended or under sanctions cannot be part of the voting procedure. And usually when we do the elections, we try to advocate and promote consensus. However, if we cannot elect someone by consensus, we will have to go into voting. If voting does take place, we need a simple majority, which means more than half of our member states. So in Western Africa, we have 15. 14 are present with us today, so we will need 8 votes for someone to be elected. As part of the procedure, if a member state has major objections, these will all be recorded. If there's a dispute, that will be for the chairperson, the current chairperson, to resolve them between member states, and decisions that are taken today will be binding on all members of ReTAC, including absent ones. Now, I did this because yesterday I didn't get a chance to actually inform you about the voting procedure, but that being said, I'm going to ask that only member states are allowed to be in the room. I'm going to have to ask everyone else to please proceed to another room. Is there another room? Yes, there's another room on the other side that we're going to have to ask you to go to while the procedure takes place. I'm going to ask Dr. Coco and Professor Aliko to stay with us in the room for the procedure of the elections, and Mr. Mudu. Thank you, everyone. Yalla ruho. Yes, you have to, you will be called back once the elections are over, and we will publicize the results. But for now, I'm going to ask everyone who is not a member state to leave, and I'm also going to ask member states to have